Yes. Yeah, for this one, yeah. Yeah, I mean, once we.
Check 1 2, check 1 2, check 1 2.
Try to think about every day I leave the house. At least that's why it's my plan.
And I go out to try to walk with the But, you know.
That would be good.
I thank you for that. I made a video and I've done it. Okay. Good for it. Good morning.
Hey, son.
How do you?
Don't you get?
She's like.
You may be down this way now, but.
It was blue on the. Yeah.
No. No. We need also. When you, I think I've got, agile. No, I think it's today. I think it's quite a little. Unique, making, I already have. It hasn't even been 12 hours. Oh, did I do the letter? The reason that I repeat, Nick, or. Because I'm pretty sure my body is going, we chop out that. I don't even know what. I never did. Like, it was all by accident, basically. Using urban state location and edit down, like it's just browse on it, get bored. And then I went back to DC. Like it. Or like center thing. But so that goes. Yeah. That's absolutely develops the different, like in front of my eyes, brings the dog. Right. And then also litters. Same thing with smoking. Like, public. So it smells like right away last time I left in Iceland. It was sick. They went to that time. Good morning. Good morning. How you doing? Good. How are you? Good. Good. Proud to be here shortly. I didn't have. And I never saw it. Yeah. Yeah, I can see it's that.
You get. This way and that way. The projector is all on your faces. How about there? A little further. It's right there. Keep going. There we go.
Okay. We're down one more on all of them.
Okay.
Right, go ahead. Any batteries with it?
You want me to take another?
Changing the glass.
I'm working on it.
That it was like 4 Yeah. I'm wondering where. That in and.
Let's switch to.
So this downstairs. Yeah, how you doing? Thank you. Oh, you don't worry. You can cash up here. Don't. Also, it's still. Yes. You gonna move? You don't have some music. Yeah. 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 That's fine. Oh, yes. You didn't know my family now, then it's. How you doing? So you can get my friend. I don't just say. I think you never told me it was going to be accomplished. You have to go to the park. That's it. No, thanks for stopping. Good, how are you?
Nobody wants to use that, so you know. You have to understand that, so I'm gonna say good. So you have graduation exactly, yeah. You just put stuff down. With my daughter, so we know she's gonna do it.
Staying great.
It just changed.
Good morning. Good morning, everybody. I'm State Senator Harold Jones out of Augusta, Georgia, representing Senate District 22. to start off with the Senate Study Committee on Improving Family Caregiver Services. I want to thank Augusta University for allowing us to have our meeting here, of course. Thank Senate staff who has made the trip from Atlanta to Augusta. Thank Senate staff, also from the my staff member, Chief of Staff Ross, who also made the same trip from Atlanta. And of course, we have senators here who would introduce themselves in 1 minute. And they've also made trips from out of town to actually come to Augusta. So I did want to thank everyone for coming here. And of course, all persons who came here to also view the proceedings. If you actually want to have public testimony, which will actually start around 2 o'clock, there's a sign-up sheet right over there, I think, where the water is, and we'd be glad to have that testimony. And that will also be for anybody who comes in later too. So what kind of brings us here today? And obviously this is a need, and we'll be discussing the need that exists in Georgia. But I would just tell you one of the things that brought it so close to myself. And it was June 7th, 2019. I'm coming home and I get a call from my mom. And I'm thinking she wants to just ask me, as she always does, do I want dinner tonight? And I'm ready to tell her no, because I have a dinner actually plans that night. Instead, she says, we think your dad may have had a stroke. And I said, well, what do you mean you think he did? And so from there, we went to hospital and spent a month and a half there. And then we came home. And when we came home, little did we know we were actually now going to be caregivers for him for the next 3 years, and unpaid caregivers. Myself, my mom, my sisters, and also nurses that we had to employ. And so I remember just wondering, what are we supposed to do? Here we brought him home, but what do we do now? And so we had to jump on the phone, start calling nursing care, because the paperwork, of course, to bring in the services he qualified, that wasn't going to be ready at that time. And third thing I remember is, among many, is when we finally got all the paperwork done. We've been using private nursing care. She said, okay, we were approved for 12 hours. And I said, well, okay, 12 hours, that's not bad. I can still go to work. I come home, I do the late shift, night shift, I stay at night. We can work through that. She said, no, it's not 12 hours a day, it's 12 hours a week. And I was like, we're in a whole nother world right now then, because we need way more than that. So what brought my attention was hundreds of Georgians right now, today, right this moment, experiencing that first phone call, or they're experiencing that trip home from the hospital and wondering, well, what do I do now? Or they're experiencing, well, this was way more than I ever thought. And they now realize that they're an unpaid healthcare worker. That's what they are. And that's the task that they're faced with. And our task is to try to see how this state can improve that, improve those things that people go through, whether it makes it easier for the paperwork, whether it's direct pay, whatever it may be. And we're going to do that through, number one, bringing attention to this issue. And number two, actually trying to find some real resources and also understanding some solutions that we can come up with. To help us get to that particular point is yourself, those who will be testifying today in the subsequent meetings. But also we have senators that are on this particular committee, and I'll allow them to introduce themselves. And I'll start to my right, which is going to be Senator Kenya Weeks. And then from there, I will Senator Kenya Wicks, and then go from there to my left and allow persons to introduce themselves. And also we have Senator Ben Watson also within this committee too, who also will be coming. Senator Wicks.
Good morning, everyone. As stated, I'm Senator Kenya Wicks. I represent District 34, which encompasses Fayette and Clayton County. Thank you for having me.
Good morning, Senator Chuck Huffstetler. I'm out of Rome, Georgia, and am chair of the Finance Committee and on Healthcare Higher Education. And like many others, and we can talk later, but we've experienced a lot in our family with this, and I certainly see it in the hospital every day with the people that we have there, and look forward to this important committee.
Well, good morning. My name's Larry Walker. I'm from Perry. Chair of the Insurance and Labor Committee in the State Senate, and I'm an insurance agent for my career at home. I really appreciate Leader Jones bringing this topic to our attention and chairing this committee. I have worked in my career over the years, about almost 30 years, with home care providers and IDD providers and assisted living folks, and know knew secondhand the challenges that families face trying to take care of their loved ones. But as I get older, and of course my parents get older, it's starting to become a more of a personal reality for me, Leader Jones. And I look forward to the conversation. Ever since COVID, one of the main things I hear from my constituents is shortage of workforce, shortage of labor, the challenges with workforce. And certainly it is very acute in the healthcare field and the home care field. And I do hope we can identify some unique ideas and solutions that we can bring to bear to help with the workforce challenges.
And also, Senator Walker, is going to be, we anticipate being the new Senate Pro Tem, which basically means he will be the total leader of the Senate. I'm the minority leader. You have a minority leader, majority leader, and then you have the top person in the Senate is Senate Pro Tem, and we anticipate him being the new Senate Pro Tem once 2026 comes. So we are very happy to have a person of that stature here. The first person to come testify today, absolutely, please clap for him. It's a very important job. Is if we have Deborah Miner from Director of Agent and Area of Agent and Agency, Central Savannah River area. Thank you.
Just speak up. Okay, he has me now. I can hear myself. Well, good morning and thank you for the invitation. So today I'm tasked with providing information on the overview of the aging population in Georgia and the United States. I am, as mentioned, Deborah Miner. I'm the Aging Services Director for the Area Agency on Aging. Okay. What is the Area Agency on Aging? I'll go ahead and say we're the AAA, not the travel agency, but we're the AAA. And what is an Area Agency on Aging? We are a public and private nonprofit agency. And our job, we're designated to provide and to address the needs and concerns of all older adults in the region. So primarily, we're responsible for a geographic area. We coordinate and we offer services that help older adults to remain in their home as long as possible, whether it's personal care, whether it's adult daycare, whether it's a personal care home, respite services, just mentioning some of the services that is offered through the agency. We're largely funded with Older Americans Act funds that's administered through the Department of Human Services, and they are in the room today, as well as Medicaid, which is administered through the Department of Community Health. We also receive monies through grants as well as private funds and donations. So we're your one stop. There are 12 across the state of Georgia, and everyone has an area agency on aging that covers the 159 counties in Georgia. Let's start with the percentage of seniors in the United States. The United States average population is 65 years old and older. By state, Georgia makes up 13.8% of the population that's already 65 plus. 1 in 6 people in the United States I'm going back to the census data. So 1 in 6 people in the United States were 65 and older based on the 2020 census. Between 2010 and 2020, the population for 65 years and older were the largest growth and the fastest growth that they've seen since 1880 to 1890. Can you believe it? We grew astronomically 5 times the rate. And why? The increase is based on the baby boomers. We have any boomers in the room today? So the baby boomers, you are driving these numbers, and they started turning 65 in 2011. More census data. Centenarians grew 50% since 2020. Excuse me, since 2010. You know what a centenarian is? How old are you if you're a centenarian? You're 100. So they're on the increase. Also, for people aged 70 and older, the male population, they outgrew women. Can you believe it? The 70 plus men. So age 65 and older more than doubled between 1940 and 2020. So we more than doubled. So I want to show you a graph here of persons age 65 and older living below the poverty level by race and Hispanic origin. Anyone know why? Just think to yourselves why it's important to understand how many people we have living below the poverty level. Living in poverty often results in significantly poor health outcomes for older adults. Why? They can't afford the medications. They have decreased access to care. So they have high out-of-pocket cost as well as the lack of transportation. They struggle to afford nutritious food and also higher risk of disability and increased social isolation. So it's important we know what population we're dealing with. What group of people does it affect? Here are the living arrangements for persons age 65 and older from the census from 2023, just some extra data. Living arrangements here is defined as either living alone or living with others. And so the census data says that you look at it for men, how many are living alone? So they are living with a spouse or a partner. That's the dark blue on both of the graphs. And you see how that's broken down. So one of the factors that can determine some degree of risk is disease. So when people are living alone, they are isolated, they won't eat, they don't take care of themselves. And also what's happening is they are depressed, they're lonely, and they kind of involve themselves in some health-threatening behaviors, such as alcohol drinking and smoking, less physical activity and poor nutrition, and they have sleep disorders. So that's who we're dealing with. Look at the age. Interesting, just more interesting from the census. Children under age 18 is down. Wonder what that means. But the biggest decline was among the under 5-year-old group. So contrast, if you look in the orange, the older population grew by 38.6%. So we have less people being born, and the people that are here are living longer. Okay, I heard somebody say, okay. So I want you to take a look at this graph here. And I want you to see that from this graph, it's from the census as well. From 2020 data, we're looking at the area between 2010 to 2020. So the population during that time that was 60 plus, that was the largest ever 10-year numeric gain. We're living longer. Largest ever percentage point increase of the total population. And these people are 65 plus, and they had the fastest growth as you look at this map. So I want to paint a picture of what we're dealing with as we start talking about healthcare and caregiver services. I just explained this to you. And here's another graph. And on here, you're going to see where the fastest growth, you look at this between the years of 2010 and 2020, Look at the growth of individuals aged 65 to 74. Look at that market increase from 75 to 84 years old, from the census in 2010 to the census in 2020 and onward. So we see that age 65 plus is the fastest growing area. So as the baby boomers move into the next phase from 75 to 84, we're going to look at a rapid increase there, just because the baby boomers are going to they're going to age from 65 to 74 over into the 75 to 84 group. So that group is going to increase. That's what expected in the next census. By the next census, that's what they're suspecting. It was very interesting to look at the numbers and then to see that although 65 to 74 is increasing now, it'll start to go down as the baby boomers leave that phase. Okay. That was me just explaining what you just saw on the graph. So the age group 65 to 74 and the 95 and over saw larger growth. So remember what I said about the centenarians, that they're on the increase? Data shows it. Okay. Future forecast. By 2020, the baby boomers will move completely into the 65-year range. By 2030, all the baby boomers will be in this phase, 65 onward. Then by 2040, it's estimated that 78.3 million Americans will be in the age group here of 65 plus. Now let's come home. Let's come to Georgia. Georgia's aging population. Georgia has the 9th fastest growing 60 and older population, and more than 20% of Georgia's population will be 60 and older by 2030, an increase of almost 34%. It's a lot of people. I pulled this slide from the Georgia Council on Aging website, and they're represented here today, who they advised the state government on aging issues in Georgia. And they had a study pulled from Georgia Rural Health Innovation Center. So 14.6% of Georgia's overall population is 65 plus. The proportion of Georgia's 60 plus population is projected to grow in the next 20 years in rural areas. So we're not only talking about Atlanta, we're talking about rural Georgia. Rural area aging population. Georgians 65 plus make up 19% of the population in rural counties. This percentage is projected to increase to 22% by 2030. So as you look at the graph, the red is 60 plus, the blue is 65 plus, and the black line is 75 plus. I just mentioned Georgia Rural Health Innovation Center. Just want to give them a shout out. They're at Mercer University. Aging populations also from rural health. As baby boomers increase, rural areas of Georgia are disproportionately older. Of the 100 oldest counties in Georgia, 94 are rural. The aging of Georgia's rural population is leading to an increase in the number of rural caregivers. So if you have the population aging, their caregivers, no doubt, are aging, who already have their own health concerns and health issues. So we need to look at that. What does our infrastructure look like for the person who's already receiving the care and the caregiver? Just numbers to show you 65 and older by state for 2022. You see the numbers for Georgia. So Georgia stats on 65 plus age group, 10% poverty rate, 92%. Remember, I'm only talking about Georgia's 65 plus individuals. 92% collect Social Security benefits. 1 in 5 continues to work. 54% do not have private retirement income. They're impacted by rising healthcare expenses because they're living longer. Women outnumber men. 29% increase in depression, and they have at least one chronic health condition. And they're one of the fastest growing groups. This is Georgia's data. I saw this report, I couldn't resist putting it up. Based on 2022 calculations, the average 65-year-old in the United States should expect to live another 18.9 years.
Yeah.
Also, Georgia ranks among the bottom 24% of the country as one of the least healthy states for older adults. We were number 39 out of all the states. So what does that mean to us? As you look at persons getting older, you probably have lost a spouse, you living alone, you have that one at least chronic condition. And if you are spending money on health care, you're not receiving that much in because you're on a fixed income. Where does that leave us? So today, my job here was to show you what the aging population looks like in the United States and in Georgia. Any questions?
Yeah, I have one. And thank you so much for the presentation. One of the things you were speaking of, one is a comment, and also one is a question. One of the slides you had about the states and the older population, Georgia, that slide actually would show that Georgia is the 4th fastest growing state as far as the older population growing. So interesting fact there. Then my question is, we were talking about the rural counties, 22%. What are some of the things that you see when you talk about infrastructure issues that exist in those rural counties, those rural areas, as we talk about caregiving and also aging in general?
Okay, I'm glad you asked. I am a former caregiver, much like you, Senator. Mother had a stroke, lived in rural Georgia, and I'm a registered nurse by profession. And I was faced with caregiving. What do? This is what I do. But what do I do when it hits home? So when you're in rural Georgia, the services are not readily available to you. You don't have the income. You are at poverty or just above poverty. You cannot pay for services. So your out of cost of care cost is higher because you are aging or you had an incident. So all of those factor into the services are not there. The clinicians are not there as you go to rural Georgia. So you may have to travel. The lack of transportation in rural Georgia. You know, we own land. We're land rich, but we were money poor. So to leave my home to get to a newfound diagnosis of dialysis, it was another 30 miles. How do we transport you now that you can't walk? So the availability is not there. The access is not there. The lack of the money is not there. And what you have, you're trying to preserve it and hold on to it. And it's just a real factor that when you are living in rural Georgia, we believe in keeping individuals at home. Yes, we kept mother home for 10 years, and I'm a long distance caregiver, went every weekend for 10 years. Yes, it burns out the caregiver. So as the caregiver burns out or as the caregiver burns in place, or pass away because they're not taking care of their own needs. There is a need for family caregiving. There is a great need for services, more resources, just the gamut. There is the need for more. And I hope I answered your question.
Yes, let me ask you one quick question on personal. Did you think being a nurse prepared you any better to be a caregiver necessarily?
Not the nurse part of me, but because I'm working with the area agency on aging and always did home care, I kind of knew how to maneuver a little bit, but it didn't help the fact I had facts, I had the knowledge, but we went to rural Georgia. What I knew happened in Augusta wasn't happening in rural Georgia.
Right. Absolutely. And I just asked that because a friend of mine is actually a doctor who faced that. And she was like, I have no idea even what to do. And so it's just very interesting when you're thrust into that role. And your lack of knowledge is really huge, quite frankly.
When that baby comes home like that,
Right.
what do I do now?
Yeah, exactly. That's
It's the
exactly it.
same thing.
Thank you so much. Thank you. Thank
Absolutely.
you.
Any other questions?
The least healthy state bothers me.
What does that mean? Us being the least? When they run studies and they're asking specific questions, we just weren't passing the mark. Think about the chronicity, what diagnosis you have, at what age. You know, in rural Georgia, you eat what's accessible to you. You don't have the money to buy the most nutritious food. And if the doctor says you need this medication, you may not be able to purchase that one, but what's next? So you have to live in order to make it, but you can't go broke. So yes, Georgia is lacking. Services are not available here as well.
So based on your personal research as well as your professional background in nursing, what are some of the ideas or solutions that you will have that you would love to share to address some of the concerns that you mentioned?
To address the concerns as far as advocacy is very important. You must come out to any advocacy event. You must make your voice known. If you're working in the arena, listen to the caregiver. Listen. You'll learn a lot by just listening. I know caregiving is a hard job, and I feel that if we can continue to bring the caregivers to the table, we will learn the needs no matter what type caregiver you are, whether it's for dementia, Alzheimer's, or just a physical disability, just caregiver in general. I believe we learn more by listening and doing these studies and then applying some type of solution. It may not all work the first time, but you try and you try and you keep plugging away at it.
I have a question for you. Given your situation and your status when it comes to home health care, how would you give balance in work and home health care and transportation and resources? Can you elaborate on that a little bit?
How do we give it?
Or how did you balance work, home health care, transportation, and the resources? Can you elaborate on that a little bit?
So personally, I'm a person that believe in care planning. Just from school, care planning. Your care plan is going to be different from mine. Senator, your care plan, I promise you, was different from mine. So my sister and I had a task of figuring out what to do. She was like 3 years from retirement of having to put in 30 years. She's like, well, I'll just take early retirement. I'm like, nope, we're going to figure it out. So what we did was she worked. She was caregiver. She had to move in with mom, leave husband up the street. She had to move in with mom. And she spent the night Monday through Friday. And I would come in on the weekend. We brought in a paid caregiver out of mother's funds and our funds. Remember, we just above broke. So you didn't qualify for anything. And you know, if you, like I said, land rich and money poor, you know, we just missed it. And so what we did was put that in place, had a nephew that would take her to dialysis. We ended up having to buy a van, always head on the swivel when trying to figure out what I'm going to do with mother. Driving up Bel Air Road one day, it was a van parked. I almost ran off the road. I turned around, went and looked, there was a number in the window. And what happened was it was a person who had a disability. The van was already equipped and ready to go with the lift in it. And we were able to purchase that. And we had to design our own care plan. It's not what's in the book. It's not what I learned in nursing school. It's just not. It's what fits that family. Did you hear Senator say, well, I'll take the night shift? You have to figure it out for the family. So I feel like every family will be different. It's based on the dynamics of that family. Who's available first? What do you qualify for? Roll those into place and then work it out. I think that's the only way you can do it.
Do we have any other questions from our panel? With that, I want to thank you so much for your presentation. Thank you. Oh, do we have one more?
There were other savings, for the age 65 and above, as far as like, retirement saving. I was wondering if there's a way that the city would can help address the financial challenges that we're having with having the income to, care for our age.
And that's one of the things that we'll be looking at. So each meeting has kind of like a theme. This theme was to do an overview, look at the special consideration of the person that has dementia, also special consideration of those who are African-American caregivers. The next things would be what services actually exist. Some you actually can be paid to be a caregiver through certain services, much lower than other states. Some states do actually direct pay, almost like a job. So that actually will be our focus for the next meeting, to kind of talk about that. So each one has kind of like different focuses. Thank you. Thank you so much.
Thank you for the opportunity.
Absolutely. Next, we're going to have, thank you. We'll have Wallace White, Associate State Director of Advocacy and Rural Outreach.
Thank you. Morning, everyone. Can everybody hear me? Do I need to stand right here? Am I good right here? Make sure you have an opportunity to hear me. My name is Wallace White. As Senator Jones stated, I am the Associate State Director of Advocacy and Rural Outreach for ARP Georgia. I want to say thank you to Minority Leader Senator Harold Jones, as well as the Senate committee members, for allowing us the opportunity to speak on this topic that is both professional for me, but also personal as well. As we go along with the presentation here, there's going to be a number of great things that I'm going to share with each one of you. And you probably heard this saying here before by the late Rosalind Carter, who once said there are four kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. So again, if I were to ask you to raise your hand if any of this applies, I'm sure that every hand in the room would either go up, or either you know someone in your community that may be affected by that. When you look at a number of reasons or why or who are family caregivers, there are a number of things that we can talk about. Family caregivers are adults providing ongoing care over the past year to adults with children with complex medical conditions or disabilities. I know that with family caregivers, we also have pre-existing relationships with the care recipient, their support, such as a family member, friend, or neighbor. I know we have a lot of personal stories when it comes to our parents. So again, we definitely have the experience being the caregiver, whether we wanted that responsibility or not. What I want to focus on are statistics. And again, when I tell you this is late breaking news, hot off the presses, literally at the end of July of 2025, the AARP and the National Alliance of Caregiving released a 2025 edition of the Caregiving in the U.S. report. This report was first conducted in 1997 and is one of the most authoritative data resources on family caregivers in the United States. This is the sixth caregiving in the U.S. report. As you see here, the statistics, 63 million Americans are family caregivers. That is 1 in 4. So again, if I said to everyone, if I went to Mr. Strong here and say, if you count one and we go down the road, about a fourth of this room here would be caregivers, to give you a perspective of that. 61% of caregivers are women, 39% are men. The average age of family caregivers is 51, but believe it or not, many of those caregivers are under 50. So the caregivers are becoming more, under 50, taking care of their loved ones. 29% of family caregivers are, we consider the sandwich generations, caregivers that's taking care of their children and adults. Now, talk about trying to prioritize your schedule. Who comes first, my sons or my mom and dad? That's a reality that I had to face as well. And I know many of you may have had that same experience. 18% of family caregivers have a disability themselves. When you look at 27% of family members are caring for someone with dementia and cognitive impairments, that gives you another stressor that you have to put in to practice. I know I want to give this slide here to give you a perspective how it is in the United States, but let's come home. Let's come to Georgia. And again, I want to share with you, these figures here are actually from our 2023 update. Sources valuing the invaluable 2023 update. AARP will be putting out in January of 2026 the updated numbers. But when you see these numbers here, 1.2 million caregivers are providing over 1.2 billion care hours per year. That's 16.3 billion of unpaid labor per year, and over 7,200 that are out-of-pocket expenses from caregivers. Please feel free to take a picture of this slide because, again, it really hits home. So again, this is from 2023. I can imagine or suspect that these numbers are going to be higher within the next couple of months. So why should we care about caregivers? When you look at here, as we said before, this just gives you a little bit more information from the previous slide. So with sake of time, I'm going to continue going forward. Family caregivers face a number of challenges, having to balance the responsibilities or other obligations that could include paid employment or parenting young children. Many face many high out-of-pocket expenses or strain on the budget to take care of their loved ones. When you look here, the caregiving in the U.S. report found that caregiving is a full-time job. Would everybody agree with that? It's not a part-time. Nearly 1 in 4 caregivers report providing over 40 plus hours per week in care of their loved one. When you look at that as far as the duration, almost 1/3 of caregivers have been caregiving 5+ years or more, not just a few month type of time frame. This is something that's going to be long term. And this number has grown since 2015 based on the caregiving in the U.S. report. Activities of daily living, when you think about eating, getting dressed, you're bathing, overall, many caregivers performing these ADLs, what we call for short, nearly 1 in 4 or 23% say it is difficult to assist their recipients with these tasks. When you look at the instruments of daily living, when it comes to the grocery shopping, the transportation, as Senator Wicks stated, how do you work those things out? Over 11% of those caregivers report receiving any training or preparation to assist with ADLs or IADLs, but many of those caregivers that we're not trained. We get ready just to jump in when the need is there. So how do we go from there? When you look at caregiving can cause a physical strain. And when I say a physical strain, when you look at the graph here, over 19% of that physical strain, you're looking at those numbers of 5, being very much a strain, because how do you figure this out in your daily living? If I'm working for an employer and I say, well, mama's sick, well, they may say, Wallace, I'm sorry that your mom's sick. And I know you have some PTO and some sick time, but I need you in the office. So this is the reality for so many employers that say, well, I'm sorry, you're going to have to either find somebody to take care of mom, or you may have to find something else to do. That's the reality that many people have to face on a daily basis. When you look at the challenge of caregiving impacts for caregivers' health, and this data is based on caregiving in the U.S. as far as 2025. Caregivers' health is suffering. You have 1 in 5 caregivers report being poor or in health, in good health. Nearly 1 in 4 say they struggle to care for their own health due to caregiving. So again, if I need to go to the doctor appointment and I'm the caregiver, but I need to take care of mom, I'm gonna have to reschedule my appointment. Now that may be good for the first 1 or 2 times, but if it's a doctor's appointment that I need to go to, how do I make those decisions? As I stated earlier, training is lacking. You have over 11% of caregivers who receive medical training, but over 89% of those other caregivers don't receive any type of medical training to take care of mom or dad or your loved ones. As Ms. Deborah stated earlier, when you have people in the rural areas and if you have so many rural hospitals are closing and rural clinics closing, what do? So many caregivers, they feel alone. Almost 1 in 4 caregivers report being socially isolated, and that number is constantly growing. When you look at the emotional stress of caregivers, look how high it is here. Over 38% from these surveys that we have report having high emotional stress. Why is that so important? When you look at the data that we have, many of those caregivers experience stress because of the fact of many women, they are likely to feel these effects. Many are report their worry or concern or their anxiety increase as the result of caregiving. Sometimes you have caregiving can have a positive impact on caregivers by giving them a sense of purpose or making them feel like they belong, or they can encourage because they can see how they can try to really help their loved ones in these situations. Again, many caregivers try to manage their mental health without professional support. Again, if I have a doctor's appointment that I'm responsible for going to, but if I'm taking care of my loved one, how can I juggle that if I don't have any community supports? How can I juggle that if I don't have any family supports? Again, these are things that people are asking about every day. On this chart here, I know there's from our research, we looked at African Americans, Hispanics, Latino caregivers experience the most financial strain, spending an average of 34% to 47% of their income on caregiving expenses. I want you to hear that again, 34 to 47% of their income. Not what mom already has to the table, but what I have to bring to the table is something that many of us we face. Challenges working while caregiving. As you see here on the chart on the left-hand side, you see 70% of working age caregivers ages 18 through 64 were employed while caregiving. But if you look to the right side, 6 out of the 10 caregivers worked full-time while providing care. So whether you're working part-time or either you're working full-time, you still are responsible for making those caregiver concerns. The challenge of balancing work and caregiving. When you look at this, many caregivers find it stressful to balance their jobs with their caregiving responsibilities. According to a 2024 study that ARP conducted with the S&P Global, caregiving can be stressful, and for about a third of surveyed caregivers, which is 34%, balancing caregiver with their job responsibilities is the biggest driver to stress. Most of these respondents, which are 84%, say caregiver had a moderate or high effect on their overall level of stress. 67% said at least some difficulty in balancing work and life responsibilities. What I mean by that is, let's take a look at this. For instance, taking a leave of absence, 32% of those persons surveyed, look at that as being stress. Moving from full-time to part-time work hours or reducing their hours to 27%. Turning down a promotion, I would love to advance, but I can't make that commitment, 16%. Moving to a new team at work, 16%. Leaving the workforce for a period of time, 16%. Changing employers because they may not be understanding why I got to take care of mom, 13%. These are many realities that we see in reference to this. the policies to support caregivers, and I want to make sure that we spend a lot of time talking about the challenges that, face caregivers and the need for them to plan ahead. But how do we address these challenges? What are some of the resources that we can really help help our older adults and people of all ages to plan for a greater future? I want to make a special note to our senators here that's in the room and also each one of you here. I know ARP, we have some model language that can assist you with making any policy changes or decisions. So I don't want you to feel like you're are by yourself trying to craft legislation. We have the research and the data we can provide to each one of you. I want to put that special note on there because this is something that's so, like I said, personal and professional for so many of us. Flexibility is the leading workplace benefit caregivers want and use. Again, working caregivers generally feel supported at work. According to this survey, women caregivers with lower household incomes, and caregivers without children under 18 in the home report less satisfaction with company support. These are all the policies that individual workplaces should be encouraged to implement. When you look at helpfulness of financial support, Georgia is one of a handful of states that offers income tax credits for caregivers. The Georgia tax credit is $150 and is available to caregivers of individuals who are 62 plus. Or disabled or determined by Social Security Administration. Caregivers must relate to the care recipient by blood, marriage, or adoption. Georgia could expand this tax credit. In our research from AARP, Oklahoma and Nebraska both have comprehensive non-refundable tax credits up to $2,000, $3,000 if that care recipient is a veteran or has dementia. Many states use Medicaid to help support family caregivers, including Georgia. And also, if you look at a structured family caregiver program that offers some financial and support services to Georgia families that would deliver care at home for a senior or a disabled person, but you have guidelines or requirements that you have to meet, such as you have to live in with the person and be their primary caregiver. You have to be a biological daughter or grandson or related through a marriage or either a son-in-law. The person you take care of is the Georgia Medicaid eligible and participate under CCSP and source waiver programs. These are some of the requirements that we have for those particular programs there. Helpfulness of caregiver support policies. When you see here the percentage of respondents who would find this policy helpful, for instance, if we wanted to move for legislations, we have 39% of people saying having respite services available where someone could take or have or taking care of the recipients would give them a break. Again, when you're a caregiver, you're constantly on what I call a 48-hour day. Now, of course, many of us, we're professionals. We understand this, how many hours a day is 24 hours in a day. But when you're a caregiver, your needs, you put to the side. So that 24 hours a day feel like it's a 48-hour marathon. And you constantly are going. You don't get a chance to rest. So these are things I want us to take a look at. One of the many great blessings with AARP being here today was that we have a number of resources that can really help to the table, that we bring to the table. AARP has created a state caregiver resource guide to help many family caregivers access key programs, services, and agencies in their community. Please feel free to click on the link here. I'm not sure whether we're sharing the presentation with each one of you, but at the end, I have my contact information. I'll be more than happy to share this with you because I want you to make sure that you click on these great resources that can really help you. This is helpful because, as Deborah stated before, she's a registered nurse by profession. She understands what the human body would do from a medical perspective. But when it comes to your family members, and I agree with you, Deborah, it becomes real. I've been a professional agent for over 20 years, but when mom and dad got sick, guess what? I felt like I was doing my ABCs of caregiving. So again, I want to stress these resources to you. The next slide we have is a family caregiver guide. So if you want it in English, Spanish, or Chinese, we have those translations for you. If you need it in different languages, we have other languages as well. Financial workbook, which is so important. I know Deborah spoke about how it's so important to plan. I would encourage each one of us to take a look at this and take a serious consideration on these resources. This is a phenomenal document that can really help you with planning or even help you with those conversations. Because again, when you're a caregiver, sometimes having those conversations with loved ones are very difficult. I want to take care of mom, but mom may be prideful. Why do you want to get in my business? And there's a whole other story that you have to go through this. Or I may have a lot of siblings, but I'm the only one doing the care. So I'm stepping on my feet, and I know a lot of you felt that as well. So Caregiving Resource Center. I want to make sure that people understand this is a wonderful resource that can help you with so many different things. As you see the tabs at the top, I mean, there's a number of different things such as, I would say care for at home, nursing homes, medical, I mean, financial, just about everything that you may need. We're happy to help you with those type of things here. Again, this is the caregiving resource. Additional resources that I want to bring for this conversation, talking about family caregiving, is ARP. We have believe it or not, a Facebook group, which is right here. We have caregiver instructional videos, which are very helpful. I really enjoy these videos because, as you see here in the example, when it says apply petroleum jelly directly to the skin, these are step-by-step videos of how you can do different things, such as wound care, such as helping you with that caregiving issues. When you're a caregiver, sometimes you feel like you're the only one that's going through that situation. And many of us, that is not the case. We want to make sure that we have these type of things here. Also, having those community resource finder, this is helpful in any community. That way you can identify your local hospitals, areas on aging, different resource, home health agencies that can really help out. And also live and recorded webinars, which can really help you get more information when it comes to understanding the entire process when it comes to family caregiving. I would love to speak more, but I want to stop for Q&A because I have a colleague of mine. I want to make sure she has enough time to present as well. Do we have any questions? I promise you, I'm just warming up, so I want to make.
Let me ask this right quick and also a comment. One of the things that you had mentioned was the $7,200. Of course, that's new money that's person going to be expending, but at the same time, their job responsibilities may be going down or their hours may have to go down. So you got new money, but your hours go down.
That's true.
And then, of course, that adds to the stress that a person's going through, and it becomes this cycle. But you did mention the fact that Georgia, of course, does allow Medicaid. You can't get paid through there, and there are services. But many times I think people feel like they're alone. They don't know how to access the services and things of that nature.
Yes.
What are some of the methods that y'all use to try to get the word out about services, number one, and then also when you talking about like support groups and respite care, which is also kind of important. How do you kind of navigate that and help people do that?
Yes, Senator Jones. The best way we do that, as far as with collectively AARP, is we help to give people the resource that they need within their community. We understand that we are a major entity that's nationwide, but us being that one entity, we can't do all the work. But what we can do is we can help connect the dots for people to understand if they have issues about family caregiving. Please feel free to contact the Areas on Aging, our one-stop shop that Deborah stated, really helping people connect the dots. I tell people all the time, Senator, before I had, two sons, I would see a diaper commercial and I didn't even think anything about it. When they were younger, every time I saw the commercial, do we have diapers? Do we have wipes? What do I need? Until you go through those situations or actually being in a person's shoes, a lot of people may not realize how I don't want to say the word burden, but how much of a responsibility it is to take care of your loved ones. Once I found out for myself, as you and many of the people here, it's great to make sure that we can really talk about those things and really connect people to those resources. So when a person asks me, Wallace, can you help me with getting more information about caregiving? A lot of times I would give them the resource that we have at ARP, but I also give them the Areas on Aging so that way they can really help them navigate what type of resource they may need. Because again, they may be looking at caregiving, but there may be some other resources they may need, such as Meals on Wheels, such as, I fall and I can't get up, the emergency response system that a lot of us remember those commercials. But if people don't know who to call, they would just rely on many commercials that may be fraudulent, and you have to watch out for that, especially with, identity theft and all kinds of things going on. But to answer your question, we want to make sure that we can really help connect people to the services that they need, whether it's in caregiving, whether it could be in fraud. We have those resources that we connect not only locally here in Augusta, but also nationwide. So for instance, if you have a loved one who's in South Carolina, I can give them the resources, and my colleagues or my counterparts when it comes to the South Carolina the side of AARP.
Any other question from the panel? Thank you so much, Ms. White, for coming up.
Thank you so much again for the opportunity.
Absolutely. Next, we have Jennifer Pennington, Executive Director of Cognitive Health.
Hi, thank you so much for having me today. Again, my name is Jennifer Pennington, and I am the executive director of a nonprofit organization here in Augusta, Georgia called Via Cognitive Health. And we are a campus and resource center that's dedicated to brain health and lifestyle changes, mild cognitive impairment, also called MCI, Alzheimer's and other dementia programming, and care partner support. I also serve as the vice chair of the Georgia Alzheimer's and Related Dementia Advisory Council. Today, I want to build on the statistics and insights shared earlier by Mrs. Miner from the Area Agency on Aging and from Mr. White from the AARP. But rather than just numbers, I'll be sharing some real-life scenarios. And we've heard a few today already. We've witnessed over the years stories that can bring some of these statistics to life and highlight the human side of caregiving. So today, I'll explore 6 key areas that affect caregivers deeply and daily. Physical impacts of providing care, the ADLs. We'll look at how assisting activities of daily living takes a toll on the body and the mind. Time constraints, the balancing act between caregiving, work, and personal life, and how time is such a limited resource. The many faces of caregiving. Caregivers come in all forms: spouses, adult children, neighbors, and even grandchildren. Each brings a unique perspective and a challenge. Emotional response. From grief to guilt to love and resilience, caregiving is an emotional journey. We'll talk about what it looks like in real life. Financial stress. The hidden cost of caregiving, lost wages, medical expenses, and long-term care financial planning. And finally, we'll explore the kind of resources caregivers often need: tools, programs, support systems that can help ease the emotional, physical, and logistical demands of caregiving. So as we dive into the realities of caregiving, it's important to recognize that there is no one-size-fits-all caregiver. The faces of caregivers are diverse, and each story carries its own weight. Let me share a few examples that reflect the complexity and emotional depth of this role. The husband caring for his wife with dementia. He never imagined this chapter in his life would include helping his wife dress, bathe, and remember her own name. He's grieving the loss of the woman he once knew, even as he continues to love and care for her every day. The siblings that care for their mother or father. The older sister has taken their mother into her home. She's managing her own family's needs while also navigating her mother's increasing care demands. She talks often with her younger sister who lives out of town, but the younger sister doesn't fully grasp the emotional and physical toll. It's hard to understand what we don't see. The sandwich generation mom. She's raising 2 children while also caring for her mother, who is battling cancer. Her days are a blur of school drop-offs, doctor's appointments, medication schedules, and late-night worry. She's stretched thin emotionally and financially, yet she keeps going because that's what caregivers do. These stories are not rare. They're happening in our neighborhood, in our workplaces, and maybe even in our own homes. And they remind us that caregiving is not just a role, it's a relationship, it's a responsibility, and it's often a sacrifice. So when we talk about caregiving, we often focus on the emotional and logistical challenges, but the physical demands are just as real and often overlooked. Let's be honest, most of us have never had to lift a 200-pound adult, let alone that adult being their own parent. There's no class at discharge from the hospital that teaches you how to safely lift, transfer, or bathe someone. You've been handed a packet of papers and sent home with hope and guesswork. Caregivers often get hurt. They pull muscles, they strain their backs, they twist their knees, but they don't stop. They just keep going. There's no time to go to the doctor, especially after already missing work to care for a loved one. So they just push through the pain because the care can't wait. And it's not just lifting and moving. There's cleaning, laundry, and constant supply management, gloves, wipes, pads, creams, and more. These tasks add up both physically and financially. And with these new responsibilities come emotions. I'm sure many of you have felt these before as a caregiver. Frustration when things don't go smoothly, anger when you feel unsupported, desperation when you're exhausted and out of options, and perhaps the most painful, guilt. Guilt that you are not doing it well enough, not strong enough, or not patient enough. And these feelings are all valid. They're a part of the caregiving experience, and acknowledging them is the first step towards supporting caregivers better. So let's talk about not enough time. I'd like to paint a picture for you, a day in the life of one caregiver. You wake up early, you rouse your kids from school, and then you check on your mother who lives with you. She had an accident during the night, so now you're changing her clothes and you're helping her get cleaned up and stripping the bed to start a load of laundry. You make breakfast, you serve it, get the kids out the door to catch the bus, and you glance up at the clock. Your home care worker is supposed to arrive at 8, but she hasn't shown up. Your heart sinks. You can't believe you're going to miss work again. You're afraid your job is on the line. You scramble to make plans and manage to split the day with your husband. You go in for the second half of the day, but the stress is already high. After work, you go pick up the kids from after school care. And just like that, the second half of your day begins, caring for a parent and caring for your children. You're carpooling to sports, you're grabbing fast food for dinner, you're helping with homework, you're giving baths, you're having a few moments of conversation, and then you're finally getting everyone to bed. You're exhausted. Your back hurts. You haven't had time to look at the bills piling up. You meant to research more reliable care options. You didn't finish your work task. You're spent. And then after just a few hours of sleep, you're awoken by the kitchen cabinets opening up downstairs and wondering, what is your mother doing? Is this another night of me not sleeping well? And then tomorrow brings doctor's appointments for your mom. You're already behind at work. You're just overwhelmed. The reality is that for so many caregivers, time isn't just tight, it's non-existent. And the pressure of trying to do it all just feels impossible. So next we'll talk about the emotional responses. And we know that it doesn't just affect your body, it deeply impacts your emotional well-being. For the person that's living with an illness or a disorder, the emotional toll can also be heavy. There's often a deep sense of guilt, feeling like a burden to those loved ones. Depression can set in. You notice your daughter, she's usually so cheerful, now stretched thin. You can feel her frustration even when she tries to hide it. And for the caregiver, the emotional weight is just as intense. You want the best for your mom. You love her, but you're overwhelmed. You feel guilty that you can't do more and you can't do better. You don't want to see her angry. You don't want her to see the angry, exhausted version of you. You don't want your kids or your spouse to see it either. This is just one example, but it's a familiar one. There are many emotional responses in caregiving: guilt, resentment, grief, anxiety, helplessness. And then we have some disorders that bring additional challenges like medication changes, behavioral shifts, and cognitive decline, all of which require constant adaptation and emotional resilience. Caregiving is a journey of love, but it's also a journey of emotional complexity. And acknowledging these feelings is not a weakness, it's a step towards healing and support. Financial stress. So we've heard about financial stress that comes with caregiving, and it's very real. Suddenly, costs begin to rise: supplies, medications, transportation, home modifications, in-home or out-of-home care services. They all add up quickly. And most families are working with limited funds. You ask yourself, what's the best option? If your parents had some income from selling a home, you wonder, how long would that last? You look into in-home care, but it's too expensive. Yet your mom needs supervision. You try to stretch every dollar, but you're constantly calculating how long can you keep this up before you're at your breaking point and have to consider nursing home care because your funds are all depleted. Many caregivers are forced to quit their jobs or reduce hours because of the demands make it impossible for them to maintain employment. And once the income is gone, the financial strain becomes even more intense. You ask yourselves, how long can we live on this limited income? What happens when the savings run out? How do I choose between paying for care and paying for the mortgage? These are not hypothetical questions, they're daily realities for millions of caregivers, and they deserve attention, support, and solutions. And so what do caregivers ask for? It's not extravagant or unreasonable. It's basic support that makes caregiving sustainable. They need affordable and reliable in-home or out-of-home care. Caregivers need help that they can count on without breaking the bank. Reliability is key. When care workers don't show up, lives are disrupted. Safe and quality care. Families want to know their loved ones are safe, respected, and receiving care that meets professional standards. Flexible work schedules. As highlighted in the AARP's presentation, balancing work and caregiving often means arriving late or leaving early, taking frequent time off, requesting a leave of absence, shifting to part-time work, turning down promotions, and all of these adjustments come at a cost. Caregivers need workplace policies that recognize and support the dual care role. Skills training. Caregivers are often thrown into medical and physical tasks that they've never done before. Training provides them to provide better, safer care. Local support, whether it's respite care, education, support groups, or transportation services, local resources make a huge difference. Knowing where to turn. Sometimes that's the hardest part of knowing what's available. Caregivers need clear, accessible pathways to help. Trying to navigate the internet to find people that can help them in each community can be very challenging. Resources vary greatly from community to community. These are the voices of caregivers, and when we listen, really listen, we begin to understand how to build a system that supports not just the person receiving care, but the entire family unit. So why does all of this matter? We have a rapidly growing aging population. More people are living longer, and with that comes increase in chronic conditions, cognitive decline, and the need for long-term care. Caregiving is not a short-term responsibility. We heard it can take up to 10 years sometimes, even more. It's long-term, and many families are doing this with limited financial resources, trying to make impossible choices with what little they have. We're also seeing a shortage of healthcare professionals and direct care workers. We know the demand is rising, but the workforce isn't keeping up with the pace. Families are left to fill the gap, often without training and support or relief. And let's not forget the cost of care is high. Whether it's in-home care, out-of-home care, assisted living, nursing facilities, the price tag can be daunting. Many families simply can't afford the level of care their loved one needs. All of this has had a profound impact on work and home. Careers are interrupted, relationships are strained, health, both physical and emotional, is compromised. And this matters because caregiving affects us all. Whether you're a caregiver now, will be one in the future, or know someone who is, this is a shared challenge. And it's time we treat it like one, with compassion, resources, and real solutions. And before I close, I just would like to extend a heartfelt thank you to Senator Harold Jones for taking on this important topic for further study, and your leadership and willingness to explore the realities of caregiving are deeply appreciated. And then also thank you to each of you on this committee for dedicating your time to listen to the voices across the state, voices that are hurting and struggling and doing their best to manage the demands of caregiving. Your presence today and your thoughtful consideration of potential solutions gives hope to families who often feel unseen and unheard. Thank you so much.
Thank you. Any questions from the panel? I did have one, because you were talking about the emotional drain, of course, it goes on a caregiver, and that's across the board, but maybe touch on some of the unique challenges when you have a caregiver dealing with someone also with cognitive going down, and their cognitive skills are also going down.
When you think about the time constraints, sometimes, and you think about that one day of all the things that you're doing throughout the day, you really almost don't have time to figure out what you need to do in order to relieve some of that stress for yourself. I mean, you're digging through the internet at night, you know that there's probably resources out there, and it's just hard to figure out where you need to go. But we've heard over and over and over again that once you can make that phone call, talk to somebody, start to open that door, then you can have more access to resources and start to break some of that isolation, because so many caregivers feel like they are alone in what they're doing. And there are a ton of people out in our community that are going through the same thing. And each community, we should all strive to have support systems in place so that their voices can be heard, whether that be through support groups, through the area agencies on aging, and through the many other organizations like AARP and the Alzheimer's Association that can help.
Thank you so much. Thank you. Oh, go ahead.
Yes.
Go ahead.
I could have asked this from Wallace or Deborah too, but with all those stresses, one thing that you see out there too, and when you're digging on the internet, like you said, is quite often there is profound disagreement among family members about how you should be taking care of them. And I don't know, and maybe I should have asked this for Wallace if there's resources there, but that's quite often a big stress in families is the big disagreements that they have over, are we doing it the right way? Who should be doing what? Should they be at home? Should they not be at home? And I know I see that all the time among the caregivers.
And I mean, there's a lot of different factors in play with that situation as well. I mean, frequently you have a spouse that's caring for their loved one, and they've known that person for 30, 40, 50 years, and they feel like their choices are the best choices for their husband or wife. And then you've got children that come into play, adult children, and they see the stress that it's causing their mother or father, and they're acting as a caregiver for the caregiver. And that whole dynamic comes out in a totally different way, and they may feel that they need to be in long-term care where that's not what the spouse wants. And so you've got all these different opinions and different ideas about what the best care plan is. And that's why some of the tools like through AARP that can help with coming up with a care plan and really talking with your family members. Sometimes I have friends that have created like a Zoom chat so they could all get together and really hash it out and figure out what the next steps were going to be.
Any other questions? Thank you, Ms. Smith. Thank you so much. Thank you. Absolutely. And I see that we have Dr. Ken Hepburn, who is a co-director at Emory Center for Dementia Caregiving, and he's on Zoom with us. Dr. Hepburn, the floor is yours.
Thank you so much. Can you see my slides?
Yes.
Okay. Greatly appreciate the honor of being able to testify in front of this committee, and thank you, Senator Jones. So I'm a professor at the School of Nursing at Emory University. I'm a gerontologist. I study issues of aging, and co-director of a Center for Dementia Caregiving Mastery that I'll talk about a bit later in this talk. The key issues I want to talk about in Georgia relate to dementia illnesses. So here in the state, we seem to be a little bit above the average for the prevalence of dementia among people over 65. According to the Alzheimer's Association, about 12% of Georgians, or about almost 190,000, are living with dementia illnesses. Strikingly, one of our counties, Dougherty County, is the 7th most prevalent county in the nation. We have a memory assessment clinic. I'll speak to those in a moment in Albany, and that is where Dougherty is. I want to point out that the prevalence of Alzheimer's disease is higher among rural persons over the age of 65, and that's nationally. And that's, I'm bringing that out because I'm going to circle back to issues around rural caregiving. Echoing what other speakers have said, in Georgia, about 85% of those living with Alzheimer's disease report at least one other chronic illness. So if you're talking about caregiving, you're talking about caregiving for dementia, but something else. And rural residents, generally speaking, report worse health status. This is nationally, worse health outcomes and a heavier direct care burden than their urban and suburban counterparts. So I'm trying to create a awareness that I want to focus on rural Georgia in particular. Okay, there. In my work, what we see is that the key needs of caregivers of persons living with dementia, Alzheimer's and other dementia, is they need a definitive diagnosis. They have to know what they're dealing with. Dementia is no one thing. It's really it's an umbrella term for symptoms produced by 70 or 80 more than 80 different illnesses. So they really need to know what they're working with. Several of the speakers before have talked about the need for a network of supportive services. I think that's really critical. And then really echoing what Senator Jones started out by saying is that caregivers are unpaid healthcare workers. This is a role that for which very few dementia caregivers have ever received prior training. They need to understand and know how to be successful in this role. One of the resources that families in Georgia enjoy, thanks really to a tremendous decision by the state legislature, is the Georgia Memory Net. Georgia Memory, and I'll show a little bit more about that in a second. It provides the expert definitive diagnosis that families really need. It, for those who avail themselves of the services, it provides a caregiving roadmap. So knowing where to learn, knowing to whom to turn, a roadmap for that is provided to family caregivers who are served by Georgia Memory Net. It also serves to strengthen the capacities of the heroic primary care providers who are trying to help with these families. So this is a great state resource. It has established a network of locally based memory assessment clinics, MACs. These are situated in sort of the best practices and medical centers in a number of cities around the state. Those centers and the clinicians within the centers receive consultation and training from Emory physicians and others in establishing a comprehensive assessment protocol, neuropsychological and physical assessments that are given to the patients who are brought in. And then the caregivers are also given an assessment of their needs, both for their own well-being and for the kinds of resources that they need to tap into. The physicians at the centers have been provided with training, but they're also provided with regular consultation so that there's an exchange among those clinicians and with the Emory clinicians about how do we handle these situations as they emerge. So it's a very dynamic, ongoing consultation among those clinicians across the state. And then there is primary care physician training that's provided through regular GM Insight webinars. There's even continuing medical education credit provided for those who take part in it. So this is the main screen for the Georgia Memory Net. And here's the map. Let me see if I can get me out of here. The green circles are where the memory assessment clinics are, and you can see they're well distributed across the state. These are all in key medical centers or medical practices in those areas. The stars are Department of Public Health, which is the partner in Georgia MemoryNet, kind of the administrative partner. Those are offices where rural caregivers who don't have internet access can go and get telehealth assessments for their patient and for themselves. So what happens in Georgia MemoryNet is, first, it all starts with the primary care provider. Primary care provider is either says, you really need a more definitive diagnosis, or the family can come to the provider and say, I've heard about Georgia MemoryNet, can you refer me? And they'll make a referral. And then there will be an in-person or telehealth appointment at one of those clinics where there's at least an hour and a half initial assessment of the patient and about an hour long or hour and a half assessment of the caregiver. And then roughly a week later, follow-up appointments in which a diagnosis is sort of delivered and a care plan is delivered to the caregiver. Now, that care plan is shared back with the primary care provider, with the AAAs nearest to the caregiver, and to the Alzheimer's Association. So there's a beginning of a network of care that is being provided through the Georgia MemoryNet. The community service educator is the person who meets with the caregiver, and those are typically they're social workers or people who have worked as care advocates, caregiver advocates. So they're very knowledgeable of the dementia caregiving situation. There is also ongoing consultation available to caregivers through the Georgia MemoryNet, and there's a continuous connection with the primary care provider. So this is a kind of a full wraparound service that's available to all Georgians. I want to switch to the notion of caregiver training. And I was asked in the invitation to talk about a program that colleagues and I developed 30 years ago called the Savvy Caregiver Program. We really think of caregivers as being clinicians. These are people who are providing healthcare. They're unpaid healthcare workers, as Senator Jones said. They need knowledge and strategies, but mostly a sense of self-assurance, competence, and confidence for the role of guiding a person who's living with an illness that is progressive and irreversible. And doing that, sort of aiming to have days that are as safe, calm, and pleasant as possible. So, yeah, not having mom downstairs rattling in the evening through the cabinets and thinking, oh, am I going to sleep and is she going to sleep? How do we get the day to be as calm, safe, and pleasant as possible? And we really function from a principle that the person is always present. The illness is gradually eroding the person's ability to be in contact with themselves, with others, and with the world around them. And this diminishes their capacity to function independently. So it's a moving, constantly moving target that is, and the movement is idiosyncratic. So the caregiver has to understand that's what's happening. I have to understand enough about this illness to be able to respond in the moment and day to day to those changes. So what we provide in Savvy is a 6 2-hour weekly group sessions. We used to be in person before COVID, but now it's almost always virtual, 8 to 12 people, can be larger. We provide instruction, exercises in the program about the progressive losses in thought and thinking, self-control of one's behavior, control of emotions, ability to, and the kind of reaction to the world around them, and the ability to function independently. And through those, the instruction and exercise, and especially home application exercises that we give, and we ask people to go home and try this at home, come back and report on it, and then we coach them, say how reinforce successes, provide corrective instruction if needed, and teaching them how to design engaging tasks and activities. So how do you move through that day to maintain or restore calm? And you know, we do emphasize the importance of self-care, but I think caregivers are just so selfless that they're terrible at taking care of themselves. So we try to hammer on that. The program really follows a program the way we teach clinicians, nurses, doctors, however. You start from building a fund of knowledge, then provide some skills, and then you say, go try it out, and then tell us how you did, and let us reinforce you. And gradually we build that sense of assurance and self-efficacy. So what we have discovered is that Savvy and an asynchronous version called Telesavvy significantly, then we've done this in multiple federally supported clinical trials, and we've published this in multiple journals. It significantly improves caregivers' sense of competence and confidence. They feel, I can do this. I can handle what's coming at me today and what's going to happen tomorrow. And it significantly reduces the emotional effects of burden, depression, and stress. And what we also find is that it has improved caregivers' quality of life. What I also am really pleased to tell you is that Savvy is available through Georgia MemoryNet. Over the years, they've served quite a number of people, and we continue to have workshops. As soon as the workshops are announced, they get filled up. But this is something that is available to caregivers through the Georgia MemoryNet. I wanted to emphasize the issue of rural caregiving. We have in front of the National Institute of Aging a proposal that we would augment Telesavvy to work on developing capacities and sense of self-assurance or mastery for rural caregivers in Georgia. Provide training. So this is, again, unpaid worker. Provide training to this unpaid worker on how to communicate with healthcare providers, manage and coordinate healthcare interactions, create strategies for dealing with emergency department use, and strengthen home care workforce capabilities. So, for example, a lot of rural caregivers don't use home care agencies because they're not there. They have to rely on people whom they can identify to come in to be home health, essentially paid workers, but they have to know how to train those paid workers to take care of the person who's living with dementia. They also have to overcome cultural barriers for building community capabilities. There's a sense, from my understanding, that rural culture is a private culture. And so asking for help, saying this is happening, that's something people keep inside. We need to teach caregivers to say, I need your help. If we were to get this grant, it would be centered on Albany, Gainesville, and the Vidalia Max. So keep us in your thoughts and prayers. I'm co-director of the Roy Ball Center for Caregiving Mastery. We fund projects to support behavioral interventions to promote mastery in the wide variety of circumstances. So dealing with specific types of dementia, We've supported caregiver research for caregivers dealing with Lewy body dementia and frontotemporal dementia. We have looking at different cultural and geographic settings. So we have supported work in Appalachia for helping caregivers to manage their home environment better. And that's our website. And I'll just give you a couple of examples. We're currently now doing running a Keeping On Course, which is a training for mild cognitive impairment families dealing in a time of uncertainty. So how did they go about making decisions for the future that's unclear, because mild cognitive impairment doesn't always lead to Alzheimer's. Sometimes it stays static, sometimes it gets better, but they have to think about that. So we have a group program for that. We are just starting Caregiver Boot Camp. This is, again, a Roybal-centered program that is for caregivers department of persons just diagnosed within the last 6 months or a year. How do I even think about this? How do I put it together? What do I need to put in place to move forward in the future, and to feel like I can, okay, this is a really new challenge. Hadn't expected this. How am I going to feel assured that I can handle it? And we're currently testing a caregiver as navigator. This is one where, and a number of the speakers have spoken about this, caregivers have to figure out how to navigate the healthcare, financial, legal, and family systems with which they now have to interact. We had somebody on one of the programs talking about the family system, and Ms. Pennington described some of the issues around that. One of the speakers, participants, described her sister as the family's caregiver chaos coordinator. This is the person who just throws the monkey wrench into every conversation around it. And so these are some of the programs we're supporting programs for Latino caregivers. There's one of our colleagues, Dr. Epps, has Caregiving While Black. And we've got some others that we're supporting around Korean family caregivers. So that's my presentation. I'll stop there and take questions as I can. Thank you very much again, Senator Jones.
Thank you, Dr. Has there been any kind of research done concerning rural healthcare as far as dementia is concerned? Because those are very concerning numbers to see how it's kind of more prevalent there from a statistical kind of standpoint. Has there been any research to understand, is that just an anomaly? People just live in rural areas with dementia, or is there something unique about the rural areas that maybe contributes to that?
Great question. I think it varies probably from region to region. I think one of the and Ms. Miner kind of pointed out the diversity of rural Georgia. So I should have mentioned that Alzheimer's disease is twice as prevalent in African American population and 1.5 times as prevalent in the Latino population as it is in white Caucasian population. And so in rural areas, for instance, in Georgia, we have a fairly diverse rural population. The prevalence issue may be one of the reasons for there being higher prevalence of Alzheimer's in those regions. Also, issues of lifestyle, nutrition, self-care probably has an effect on heightening the prevalence.
One other quick question, because I think it's great that you have the training sessions. Do you ever, your team ever receive issues where people understand that they need the training, but they're kind of hesitant to go into it, especially when you're dealing with maybe the dementia patient who's at home, because that patient may have a great day one day and a bad day another. And so person may think, well, I don't really need training because the last 2 weeks he's been doing really
Been
well,
great.
so I don't go any kind of training.
Yeah. One of the advantages, I think, of the Georgia Memory Net connection with the community services service educators, but also with the dementia care specialists through the AAAs, is that there are resources available to people to be able to say, but I don't need this training. And having a professional say to them, you're saying that now, but just wait. This is something that's really important, and you will benefit from it, even if you don't think you'll feel that way. So I think we have capacity within the state, which probably we need to bolster, to really encourage people to get this training.
Point of contact on these issues, using doctor's office or nursing. Getting that information at the initial point of contact, passing it along, helps to transition the person along smoothly throughout the process. Can everybody hear what I said?
Go ahead
I
and
couldn't
say it
hear.
one more time, just for our public. Oh,
What I was saying was, most of our individuals who have this issue, the initial point of contact is the primary care doctor or the hospital. So that would be the place to have the most impact if that information can be shared at the initial point of contact, so it transitions throughout the process easier. And that is not happening. Some are really good at doing it, many are not. Because I'm a nurse, I'm a provider nurse. I've been in this space with almost everyone in this room for over 30 years. We deal with this on a day-to-day basis. And I constantly get phone calls about, well, how do I navigate this? How do I navigate this? How do I navigate this? So I'm spending 30, 40 minutes with a person on the phone trying to explain to them how to navigate to get where they want to get to. A lot of times these people just left the hospital.
Yeah.
So they have nothing when they walk out the hospital to act upon.
that's right. Go ahead, man, but take the mic for him, please.
And a lot of that also comes from education of the physicians and the need for that to happen with primary care physicians. My husband is an internal medicine physician, very well educated, Howard University, Georgia Tech undergrad, but he will tell you that in medical school, as far as training with dealing with patients with dementia and Alzheimer's, they don't get at that time and still now, they don't get the training that they need with that. So there's a need for that also. And the lack of primary care physicians and also specialists and access to neurologists when you get down into rural areas. You can see from the dementia plan that we have for the state of Georgia, and it's on the internet up under the Department of Aging. It tells you the amount of neurologists that are in the different areas of the state. And you'll see once you get outside of Metro Atlanta area, that number goes lower and lower. And so it's access to those professionals. And that was the reason for the Georgia Memory Net. And I'm with the Alzheimer's Association of Georgia. I'm the board chair, one of the board chairs. And we stomped in DC to get the BOLD Act passed, to get monies to come down to the states for that. And I thank Georgia for forming the Georgia Memory Net. It's a great service because you can have access to a professional in those areas where you cannot find a neurologist. And that was the reason for putting that into place.
Absolutely. Thank you so much. Do we have any other questions for Dr. Hepburn? With that, I want to say thank you, Dr. Hepburn, for your valuable information and also all the work you're doing within this particular field. Thank you so much.
And thanks again for the invitation.
Absolutely. Next, we have Alexis Williams, I believe, Director, with Government Affairs of Alzheimer's Association, Georgia chapter. Thank you.
That's well.
Good afternoon, everyone. So my name is Alexis Williams. I am the program manager for the Alzheimer's Association, and I have the pleasure to serve this area. It's truly an honor to be here today, and I'm so thankful for the opportunity to present because Alzheimer's and dementia touches so many different lives. I started as a volunteer with the association several years ago as a way to give back. As in 2017, I lost my grandmother to dementia, Alzheimer's particular. So yes, I'm a public health graduate from here, actually. It also touched me personally. So I have the opportunity just to talk about the impact of Alzheimer's and dementia in the community and it related to the caregivers. And so part of our presentation, we're actually going to allow you all to hear from a couple of our caregivers right here. So first I'll bring up Ms. Cheryl English, and she'll come and tell her caregiver story, and then I'll present, and then we'll close out with another caregiver as well.
Thanks, Alexis, and thank you so much for the opportunity to be here with you today. I'm Cheryl English, and my husband in the back, Tommy English, who is also part of our caregiving story. We're from Greensboro, Georgia, which is about 75 miles west of here. And our story is a multi-generational story. So it starts with my grandmother. My grandparents lived in New Mexico, and about 2 years after my grandfather passed, the neighbors had contacted us with some concerns of my grandmother's cognitive abilities. And so we made the decision to move her to her only living child, which was my mother, who lived in Colorado. So we moved her up. And about 2 months after we moved her up, we realized this was much more advanced than what we had thought. Grandmother was physically fit, very fit, but she wandered during the day and at night. She was agitated, and ultimately, there's a lot of anger that goes with advanced dementia, and many times that anger manifests into violence. And so one evening I was home, came in to visit, and my grandmother had my mom cornered with a kitchen knife at her throat. So I was able to divert the situation, but of course my siblings and I immediately realized that this was a situation that required more advanced skill. Grandma had lived with my mother for about 3 years and dealing with all of these situations. Grandma was moved into a memory care facility, lived there for about 3 years, and then passed away at the age of 90. Then about 2 years later, after my father had passed away, my mom was living by herself. She was a brittle diabetic, which is extreme high and low diabetes. And we decided that she no longer needed to live by herself. So my husband and I decided to move her from Colorado out to Georgia to live with us. She was fine. We were both working full time. She was pretty independent, but her cognitive abilities were declining. We were at work. She fell one day, and probably due to low blood sugar. After that, both her physical and her mental abilities began to decline. So we realized that we needed to have someone with her during the day as well as at night. So at the time, my husband's job was about 90% sales over the telephone. We went to our employer and asked for an extended family medical leave or a work from home situation. This was in the early 2000s, so technology wasn't quite as advanced as it is today. And the employer declined any support for our caregiving abilities. And so my husband offered to take an early retirement, and he stayed home to take care of my mother. Now, how many spouses would take care of their in-law? He's a very special guy back there. So my mother's situation wasn't nearly as advanced as my grandmother's, but she lived with us for about 3 years. You've had speakers that have gone through all of the mental and financial stress of caregiving. We were now operating at half the income that we had. And after 3 years, we were exhausted. Our friends had kind of alienated us. We would try to take vacations. My mom would get very disoriented whenever we would take her away from home. So we ultimately began to look for a memory care facility for her. She had a heart attack, and although we lost her, we were very thankful that we never had to make that tough decision to put her into memory care. And so, that's our story. I'm an advocate now for Alzheimer's. I believe we do have a cure in our future, and certainly better treatment. I think the goal here is really to encourage families to be able to take care of their loved ones for as long as they possibly can at home. It's less of a financial burden on the federal and state budget when people can and are enabled to take care of their loved ones. And so I have 3 asks of you. The first one is to support financial needs of those caregivers. You've heard many stories about, renovating homes, the additional care for their personal needs, food, clothing, things like that. The second one is to provide the financial support for those local services, the support groups, the education. Boy, if we had had access to education, we would have done a much better job. And probably most importantly is the respite care. Respite care is so critical to caregivers taking care of their own physical and mental well-being. And then the third one would be to incentivize employers to allow the flexibility to provide that ability for their employees who have a need to become a caregiver. So thank you so much to the committee for your work on this. We really appreciate what you're doing, and thanks for your time today.
Thank you, Cheryl. So, as she said, she shared her journey. And again, she says there is a cure, and we wholeheartedly believe in that vision. The numbers are just so overwhelming because behind every statistic, it's a real person. It's somebody's mom, dad, granddad, sister, brother, sibling, and even child. And so it's important for us to realize that over 7 million Americans are living with Alzheimer's today. That's 7 million lives that are forever changed. And when we think of the 7 million that are living with Alzheimer's of some form, we have to come in the roles of those care partners, those caregivers, and that impacts about 11 million people. When we think of dementia is that umbrella term. And so as the doctor before me already said, he was like, there's different forms. Alzheimer's is just one of the ones that we hear about the most. It's the most common cause, accounting to approximately about 60 to 80% of the cases. And then we think of vascular. We have Lewy body. We have frontotemporal. We have Huntington's, and then there's a mixed dementia. So which means you can have a combination or alls, and it's hard. So there are conditions like thyroid issues or vitamin deficiencies, high blood pressure, diabetes, where you can typically control it by medicines. But as we said, with dementia being such that umbrella term, and there's so many different forms out there, and it affects many people differently, it's hard. As I mentioned before, in 2017, I lost my grandmother to dementia, but before I was born, her mother had it. I never had the pleasure of meeting her, but when I hear the stories, their symptoms were completely different. This is her child, her oldest child, but they were night and day. What my grandmother did one thing, my great grandmother did another thing. So again, it takes a toll on those caregivers, particularly because you just never know what to expect. When we think of Alzheimer's, what is that mainly? That's the most common cause, and age is the greatest known risk factor. So are we saying that because you're 75 or 85, will you develop it? No, but the longer that you live, we've already heard the life expectancy is going up. We have many centenarians right here in Augusta as well. So the older that you get, the more risk you are for developing it. So sometimes people will hear, well, I made it to 80, so I'm good. That's not necessarily the case. It's a progressive disease where symptoms gradually get worse over time. So you will go from being completely independent to becoming dependent. In the early stages, memory loss is mild, but as the disease progresses, individuals, they'll start needing more care. They'll need help with just the basic things of life. As I mentioned already, that over 7 million individuals are living. So when we look at this graph and we see the growing number of Americans that are living, we can take a look. The number of Americans age 65 and plus, this is kind of where we look at. And then we have, the mustard color is ages 75 to 84. And then that purple color is those that are age 85 and older. We've already heard this earlier, but the populations that are at greater risk. So Black Americans are twice as likely, Hispanic Americans 1.5, and then then women are 2/3 or have a greater risk. So being a Black American woman or a Hispanic American woman, your risk is even higher. Alzheimer's disease begins 20 years or more before the onset of problems. So those changes in the brain can already start occurring. You don't really see those until later on. Some of the changes are very subtle. Again, some you don't see. And then once you start noticing those mild cognitive impairments, you realize that those changes could have been occurring for quite some time. People age 65 and older, they have on the average 4 to 8 years after a diagnosis. However, there are many individuals that live as long as 20 years, and that is continuing to change. As time goes on, we talk about healthy habits for your brain and body. So what are some lifestyle changes? A couple of different things comes into play, genetics, those things as well. That has a great impact on how you may live. The long duration of the disease contributes significantly to the public health impact. So dementia is a public health crisis that we have. It's global, it's going on. And again, as we have these longer years, we're able to live longer, that duration. So which means where somebody's living with 20 years, we think about just the price, the amount that somebody is spending in care, or how much the caregivers are having to play a role in it. Caregiving, nearly 12 million Americans are providing unpaid care. When we equate that to money, that equals out to about $413 billion a year. So again, we're already talking about we might have to reduce hours, so reduction of hours, so our income, with loss of income, or we're trying to layer in different layers of support. And it's sometimes hard. And I know we all know sometimes when we're in the thick of it, family, we sometimes don't always see eye to eye. So then now you may feel that pressure, a little bit more than someone else may, because it plays a toll on you physically, emotionally, financially, socially. As Cheryl mentioned, she was like, as time went on, those friends had really alienated themselves because they don't know how to help. You're canceling dinner plans, you're canceling trips because you're trying to take care of someone. Again, we've mentioned 2/3 of caregivers. When we look at that, 2/3 of caregivers are women and 1/3 are daughters. About 1 in 3 caregivers is age 65 or older. And so as we age, we may have different issues and health issues. And so we're putting ourselves greater at risk because again, we already heard this as well, is we now might be missing appointments because mom is falling. Or now, we're supposed to go for an x-ray, but now I got to go pick up dad because something has happened. And so more than half of primary caregivers take care of their parents, and they could easily be right now what's called the sandwich generation, where they could be raising a child, but also taking care of an aging parent. They could also be siblings. So you may be taking the role of a sibling, taking care of your sibling while also raising your kids. 41% of caregivers have a household income of $50,000 or less. Mind you, we already talked about that $413 billion of unpaid care. So the cost is pretty greatly when we think about it. 2/3 live with the care recipient in the community, as we heard. So we moved mom in, or somebody has moved in with them because it makes it a little bit easier to live with them. But now what are we doing about the place that we were in? Are we selling that? Or are we taking care of that? I mean, we renting? What are those things? So how are we managing a couple of those different layers all at one time? 2/3 of caregivers are white, 10% are Black, 8% are Hispanic, and 5% are Asian American. The remaining 10%, that represents a variety of racial ethnic groups as well. Georgia caregiver data. So again, let's bring it home to what we're facing here. Right now, we have about 384,000 dementia caregivers in Georgia. That equates to about 775 million hours spent providing care, which then turns into $13.3 billion yearly. So that's how many people are providing some type of care, some type of something to them. In 2020, typical year costs for residential services in the US varied between $52,000 for home health aides to $102,000 in private room care in a nursing home. In that same year, a study published in NPJ Aging estimated that people in the United States spent $196 billion in direct medical costs for Alzheimer's disease and related dementias. So the direct cost of this has economic and social costs for individuals. When we look at it, then we see these caregivers down, they're also living with some type of chronic condition. They're also having this withdrawal. Their friends have alienated. So now they're at a greater risk for depression. And then they also reporting frequent poor physical health. And then we have some that actually pass before the person that they're taking care of because they have neglected themselves trying to take care of them. And now the high blood pressure isn't, controlled. I was just talking to a family member a couple of weeks ago and was saying, they just moved the sibling in and was trying to take care of the parents are deceased and moving the sibling in while also taking care of children. Did not realize, been taking the medicine, is fine. Went to an appointment, finally made it to an appointment because they had to reschedule it. Made it to the appointment. So what's going on with your blood pressure? Did you take your medicine? It's like, yeah, what you mean? What's up? Well, you know what? We're going to monitor it. We're not going to change anything. Let's just monitor it. Maybe we just may need to adjust something, and kept going. They checked it morning and evening, still high. Didn't realize it because it was in the thick of it. Now, thankfully, they did make that appointment. So thankfully, they did, do what they were supposed to do and track the blood pressure like they were supposed to. And then they did adjust the medicines that it has been working. But sometimes that does not happen. Because again, while you're in the midst of trying to caregive and take care of so many people that are calling on you, you sometimes neglect yourself. What we have is Georgia Alzheimer's and dementia. So related dementia, state plan work groups. That is one of the great things that we have in Georgia that I'm proud of. And what it does is it brings together stakeholders to discuss goals, strategies, and action items. It ranges from healthcare professionals, family members, caregivers, doctors, everyone. And they have 6 different work groups. The 6 different work groups, they vary. And the first one is workforce development. So their purpose is to ensure skilled, trained staff to detect, diagnose, and support individuals with dementia. There's service delivery. So they focus on expanding access to high quality, person-centered dementia care across Georgia. And I want to emphasize person-centered because again, what may work for one person may not work for another person. What may work for that person today may not work for them this evening or tomorrow. So it's important that you're building person-centered care plans based off of the individual needs of that individual. Outreach and partnerships. They build awareness and forms community collaborations, often with faith-based organizations, nonprofits, and educational institutions. We then have policy. They evaluate laws and funding to shape strategies supporting individuals with dementia and their caregivers. We then have public safety, which addresses issues like abuse, neglect, and exploitation of vulnerable adults. Many times how many of us get a scam call? Well, we have individuals, the older individuals, especially those that are facing brain change, they were easily acceptable to answer these questions. And now you see so much going on. It also teaches for public safety to make sure that they know the things to look for. We did a presentation with some judges in another area. And one of the judges, when he was having a conversation, he says, I'm over guardianship and having to move guardianship. And I need to be able to know when I need to be able to step in better or what I need to look for when somebody is asking to be appointed or if we need to appoint somebody else. So that's important. Then we have healthcare data and research collection. That drives improvement through better data collection and ongoing research efforts. Again, it just varies, and we're always looking for people to join. You can always reach out to the state coordinator and say what your role is and what interests that you have and which ones you think will be better for you. So there was a state report that was done and that came out in 2024. And so we'll talk about that. And so in this estate plan, it was originally established in 2014. It covered a wide range of information, including the prevalence of Alzheimer's disease and related dementias in Georgia, existing resources for individuals living with it, the state's capacity to meet those needs, and how to address those needs moving forward. Updates to the state plan occurs every 4 years with a focus on creating actionable and measurable goals within the 6 priority areas that we've already talked about. So in addition to the state plan, what came out is the House Bill 571, and it was to submit a report every 4 years to the governor and General Assembly of the latest data and statistics around dementia in Georgia and progress made towards the goals identified in the state plan. With assistance from the University of Georgia's Carl Vinson Institute of Government, the Department of Human Services Division of Aging Service developed the report to fulfill the inaugural report in January 2025. This report examines data and trends about Alzheimer's disease and related dementias in Georgia within the following 3 areas. Risk factors, prevalence, and mortality is one. The second one is impact and burden on families and caregivers. And then access to care is the last one. The next few slides will highlight data from the section of the burden on families and caregivers. The data includes the estimates from the Alzheimer's Association data mentioned earlier and the latest insights on caregiving for Georgia's ages 50 and older, according to the Centers for Disease Control and Prevention. CDC data confirms Alzheimer's Association studies that the number of caregiving hours for those with an Alzheimer's disease and related dementia diagnosis increase. So when we look at this, for Georgians 50 years or older, caregiving intensity, percentage of older Georgians who have been a caregiver in the past 30 days is 23%. Percentage who have been a caregiver in the past 30 days to someone with cognitive impairment is 26. Percentage of older Georgian averaging 20 or more hours of care per week to a friend or a family member is 38. And then when we look at for 6 months, what is the percentage of older Georgian providing care for 6 months or more? So which means extended period of time is 72. So again, sometimes we get caregivers, they're going through a brief illness or something, but now we're caregiving constantly to over 20 hours a week, extended month after month after month. The percentage of older Georgians who are not currently caregivers, but expect to be in the next 2 years is 17%. So we think of it as we have maybe aging parents or, different diagnoses coming about. What does that look like? As part of the data collection for the report, Carl Vinson took a closer look at the burden on caregivers in Georgia. While there's not a great deal of state level data, the Georgia Memory Net has captured multiple surveys of their memory assessment clinic with patient caregivers. Among Georgia Memory Net patients, most caregivers are children of the patient, ranging about 40%, or a spouse, which is about 35%. Only 10% patients are primarily responsible for their own care. Of the surveys that was received, the greatest burden noted was stress from balancing their duty to care for a loved one and their other responsibilities, in addition to uncertainty about how to best provide care. You can also note that here are the numbers of caregivers that responded that they did not understand dementia and how we partner with Georgia Memory Net and others in the community to help educate care partners and others. Because again, dementia has so many different forms. That's the umbrella term. And we can have 10 people that are all diagnosed with Alzheimer's particularly, or 10 people that's diagnosed with Lewy body, but all 10 of them are different. So you don't really understand. So how do we come apart? We have a helpline with master level clinicians. They're there answering a call, again, 24/7. You can always call that number toll free, and they'll provide confidential information and support for people living with dementia, caregivers, families, and the public. You can call every day, you can call multiple times a day, and someone will be there to answer the call and talk you through whatever. We also have free education and support. One of the series that we actually kicked off last year was called the Empowered Caregiver series. And it walks through what does it look like? What is foundations of caregiving? What does that entail? Because so many people take on this caregiver role and they feel like they have to do it all. Well, now we're post-COVID, and so a lot of things have come into place, but Walmart delivery is a real thing. So it talks you through it. Sometimes that don't mean you have to go to the grocery store. You can get it delivered to make your lives a little bit easier. But of course, that's another expense because either you pay for the Walmart Plus membership or you're paying for the delivery every time. But again, what are some different things? So we talk about a foundation, how to support independence, because we want to make sure that as long as that they can, that they will, that they're doing. How to communicate effectively, how to respond to the dementia related behaviors, how to look for the resources and support that you need. What is the benefits of understanding what the warning signs are and how important it is for early detection, how that is key. Because right now there are 2 FDA approved drugs that are out there, but to qualify, you have to be in the early stages. And then we have a trial match program where clinical trials are done. And so you can go online, you're linked with different services, different clinical trials, and you fit whichever ones. So we're not just looking for caregivers. We're not just looking for people who had a history of it. Because again, as I said, there's many different forms. It affects everyone differently. So we're looking for many people so we can better understand the disease. Because at the end of the day, we believe in our vision of a world without Alzheimer's. We have an app that's available. It's called My All's Journey. And so there's 2 different pathways, but you can receive support, guidance, and connection for newly diagnosed people and care partners all in one app. So you choose the journey that you're going to go on. So if you're living with dementia, you choose that journey. If you're a care partner, you can choose that one. And it provides personalized guidance, trusted resources, and local connections. And so it helps you engage cognitively. It helps you stay involved. It helps you see the resources that are available so that you can know that you're not alone. We also have support groups. We have 4 support groups that are right here in Augusta, but we have support groups all throughout Georgia, within the states. And so you can always connect with those support groups because it's nothing like being around people who has a similar story with you. Because that way it validates you. And so you can know, like, I'm not here alone. I do understand somebody else understands what I'm going through, and which is so important. And we'll finish off with another speaker from one of our other caregivers of this area, Ms. Bonita Jenkins, and she will share briefly of her story of caregiving.
For my mom at 90. On Mother's Day, you came to stay. A new chapter began that day. Now roles have shifted, tables turned, and from your wisdom, I still have much to learn. At 90 years young, your spirit shines bright, even when memories slip from sight. Through laughter, stories, and moments we share, I'm honored, Mom, to give you my care. Good afternoon, my name is Bonita Jenkins, and I'm a baby boomer. This past Mother's Day was unlike any other Mother's Day I've had. That was the day that I moved my mother, who is 90 years old, in with me. That day I became not just her daughter, but her full-time caregiver. Since then, my life has been filled with love, challenges, and more than a few funny stories. The kind of stories that I tell my friends and they say, you need cameras in your house. Maybe I need a reality show. And honestly, they might be right, because every day with Mom is unpredictable, but every day teaches me something new. Growing up, my mom was the one that kept us going and told us what to do and how to do it. Now the tables have turned. I'm the one setting schedules. I'm the one managing meals and reminding her of things. And sometimes she'll look at me and say, I'm so glad you're my daughter, but who would have thought that I would move in Augusta in your home with you? And I look at her and I say, Mom, my home is your home. Of course, there are hard days, as you've heard. Dementia brings its share of challenges. Some days she remembers clearly, and we can laugh and talk about old times, and other days confusion just sets in. But in those moments, the humor keeps both of us going. Like on Sunday morning, she asked me, where are we going? About 15 times. Where are we going? And finally, I looked at her, I said, Mom, we're going to the club. And she said, what? I don't go to the club. And I said, Mom, it's Jesus Club. And then she said, oh, okay, so we're going to church. And so then off to church we went. And I know that I'm not alone in this journey. Right here in Georgia, like everybody said, there's over 1 million family caregivers just like me, providing over 1 billion hours of unpaid care every year. That's why today is so important to me. We are here because of Senate Resolution 393 that was established to help all of us emotionally, physical, and financially. I especially want to thank my friend Senator Harold Jones for not only his leadership in creating this committee, but for your heart. Senator, you've shown us that it matters. We matter. Our voices matter, and that change is possible when leaders truly listen. On behalf of myself, my mom, and the many caregivers across Georgia, thank you. Caregivers are taking on a more complex resolution, often expenses that we didn't even know we had. Caregiving is not cheap, as you've heard, and it has expenses that you've never thought that you would have to do. When I was little, I thought money grew on trees. I know now that's not true. I'm having to juggle a full-time job, a child in college, buying groceries, and then even an ad in the mouth to my household. Caregiving is not glamorous. It's medicine schedules, doctor's visit, making sure the stove isn't left on, and sometimes convincing her that, yes, mom, you've already taken your medicine. But then something funny happens. And then, she calls me almost every day and asks for just a little hamburger. And she knows that McDonald's is down the street. And my daughter was like, you got to stop feeding her hamburgers. And so it's a struggle. But mom used to provide 3 meals a day at our family. I struggle to even to turn the stove on. And my husband can tell you that. I want to thank my cousin Phyllis Kitchens, who he's my mentor in many ways, but she has been so passionate about Alzheimer's all over. She's been at Washington, and so it's in our family. And she is the one that connected me with Alexis and the people here in Augusta. That time she connected me, I was just doing the Alzheimer's walk. I knew it was in our family. I didn't know it would come home to me, and so. The meetings really become my therapy sessions. I apologize to all the people that I meet with. I'm like, I'm sorry, but I'm just asking all these questions. But that's why they're there, for the help. AARP website has been wonderful. I had no idea that I would be on that site so much, but I thank you. I'm glad that my mom will join me this year at the Alzheimer's Walk on September the 27th. I'm really excited about that. I want to thank Alexis for asking me to share to you today, because this is new to me. And Cheryl, I would love to talk to you because you've been through what I know that I'm going. This journey has already taught me patience, compassion, and resilience. It shows me how strong I can be even when I feel weak. And it's deepened my love for my mom in ways I've never expected. I appreciate my husband, Jay, who is here, my children, Jada and Jaden, who I promised, I said, my mom is my responsibility. I just need your support. And so, I want to thank my friends. Some of them are here. They listen to me. They come and pick me up, take me out, make me laugh when I need time off. My husband and I joke, I'll go out with them and he'll call me, he'll say shift change. And so then I know it's time for me to come home. So that's our joke. So when mom moved in with me on Mother's Day, I thought I was giving her a gift, the gift of care, comfort, and my support. But in truth, she has given me the gift of time, laughter, and love. Caregiving is not easy. It tests your patience, your strength, and sometimes even your sense of self. But it also teaches you to cherish the moments that you have. So yes, maybe we do need cameras in our house. Maybe the world could use a reality show about dementia, because in the middle of dementia, there's still joy, humor, and most of all, there's still love. But as we continue to work together, and I promise I will work and learn and do everything with SR 393, I'm grateful for the leaders that are here, the caregiver supporters. And so that just lets us know that we're not alone, and there's thoughtful, meaningful change on the way. We love and need all the support we can get. But before I take my seat, I have only one request of everybody in the room. If you would wish my mom, who is over there, happy birthday. She will be 91 on Friday. And I'm so blessed to have her. Thank you so much. And believe me, when people say you don't know how blessed you are, I know how blessed I am. Thank you, and blessings to all of you.
But that concludes our presentation on the impact of caregiving for those that are living with dementia. Again, my name is Alexis Williams. I serve as the program manager for this area. And if anyone have any questions, I will listen to them now or answer them now.
I want to thank you.
I want to thank you so much for your presentation and for those that came and spoke. So I really appreciate that. But I do have one question when it comes to the multi-generational caregivers. How easy or accessible for childcare for children and the parents for the resources for childcare? Has it been brought to your attention?
I haven't seen that brought to my attention a lot, but again, as you're in those multiple generations, and so sometimes the children, and I tell people all the time, is that we need to make sure that the children is understanding what it is, because the children is sometimes is home with grandma and grandpa, and so because they are the caregivers, they're the ones that's providing watch while mama's still working to try to navigate, because again, we already heard how costly it is, and so that does shift. Because now we can't maybe keep them home with grandma and granddad, because now we're needing some extra care, because we're needing extra care for them. So you can definitely see the challenges where they're having to lean on after school care, boys and girls clubs, and those things. And again, which is another added expense.
And I have one more question. I do apologize. When it comes to Alzheimer's is the care is intense. When it comes to modification to your homes, how the resources for that, have you experienced that? And what kind of advice would you give in reference to the resources for modifications to home and stuff like that?
Okay, so a couple of things there. We have there's a book called the 36-hour day, but then there's also is Living Your Best Life with Early Stage Dementia. And so it has different chapters again on different modifications that you can go ahead and start putting into place. Another thing that we also recommend that is you can build through insurance is something as simple as occupational therapy, because occupational therapists, they come out in the house and they can look at, okay, the rug needs to be moved, or this nightstand could be a trip hazard when they're trying to get out the bathroom, or maybe they're trying to put their socks on, so they need some reachers. So then they can recommend the different things that you need in the house, but they can also say, okay, maybe this lock needs to be moved up so that they can't easily access it, or a screen door needs to be placed. So there's another layer of a lock to put in. But again, it varies. Some people are wanderers and some are not, and they may not wander, but they might be trying to cook in the middle of the night. And so there's also things where you can it's a flip to turn the stove on and off. But again, it's easy. I always recommend somebody to come actually in your home so that they can see what they're actually working with.
Go ahead.
Shift change.
Y'all don't know that's Bonita's husband.
We give her my business card. Call me because I set up interviews on our morning show. We need to get the word out and continue to get this and support the community, the state of Georgia, and the world itself.
Yeah.
Thank you. Thank you.
Thank you. Any other questions? Thank you so much for coming. We appreciate
you.
it. Thank you. Thank you. And next we have, I see Dr. Moss is on. So we have Dr. Karen Moss from the Ohio State University addressing us. Thank you.
Good afternoon, everyone. It is my pleasure to be here. I am going to go ahead and share my screen. And if somebody can let me know that you can see my title slide only here.
Yes, we do.
Wonderful, wonderful. I too would like to extend happy birthday to the mom of the most recent caregiver speaker. So happy birthday. So as mentioned, I am Dr. Karen Moss. I am an associate professor in the College of Nursing at The Ohio State University, as was mentioned. I have the privilege of speaking to you, like at least one of our presenters previously, as a member, a dedicated member of the most trusted profession. I am a registered nurse. I am also a nurse scientist, and I work to improve health outcomes for family caregivers of Black people living with dementia, and this includes Black men. My focus on this population is because of the scientific evidence that you've heard here about the high risk, actually highest risk for dementia existing among Black individuals, which translates to the fact that Black caregivers are at also highest risk for the negative physical, mental, psychosocial, financial, and I can go on, outcomes that caregivers face because of Black individuals being at greatest risk. Thanks to the generous invitation of Senator Jones, I get to share with you just briefly on the plight of Black men who are family caregivers, and I am grateful for this opportunity to share. Particularly, I am grateful for this opportunity to share on this, what I will describe as an unseen and unheard segment of family caregivers. And I have seen evidence of this in my own work, which I will share about towards the end of this presentation. I will also try to spotlight some potential solutions that I've seen and areas where more work needs to be done, which, as all of our previous presenters have mentioned, is vast. So more and more in my own research on caregiving for Black individuals, specifically living with dementia, we get these glimpses or these glaring sightings of what caregiving looks like for Black males. And, you know, when we think about the gamut of caregiving responsibilities, the stigmas associated around caregiving, specifically caregiving for individuals such as those living with dementia, the visibility of Black men in society in these caregiving in this particular caregiving role, or these caregiving roles as family caregivers more broadly, is shrinked. So all of the wonderful statistics, which I'm so grateful I do not have to dive into because my previous presenters did such a wonderful job of laying out for me, and I thank you. For all of these reasons, we get to see the magnitude of the needs in our communities for family caregivers in general, for Black family caregivers, for family caregivers who are male, and also not forgetting those who are caregiving for people living with dementia. And so while the jury is still out, and this is the one thing that's always so stark with the family caregiving data and these statistics that we see, we know that the numbers, in particular, as we think about Black males, these numbers are woefully underreported. So the likelihood of Black men stepping forward and saying yes, raising their hand and saying, yes, I'm in the caregiving role, one, and number two, I need help, is decreased. Again, because of the stigmas surrounding this, not knowing how they will be perceived in the community when they do raise their hand and say, yes, that's me. So notwithstanding that, as have been alluded to, I want to just say, you know, we also have to acknowledge that Black men, as was already stated, have some of the worst health profiles among Americans. So if you think about, you know, all those different segments of that wheel of wellness that I described that are challenging for individuals in the caregiving role, when you think about someone whose own health is already at risk for decline at baseline, and then added burdens surrounding caregiving without the needed supports, again, it just shines a light on how great the needs are. And so the fact that many of these men are suffering in silence is real, and often doing things alone. It was mentioned earlier about the sandwich generation. So yes, you have these men as pictured in the top picture here who are at various ages in their adulthood, young adults, older adults, and then you have men who are raising kids and also caring for, you know, another dependent child, a dependent child who may be living with chronic illness, also caregiving for older adult loved one, a parent, grandparent, you name it. And the National Caregiving in the US report that was recently released, previously mentioned, talks about how in the general population, 13% of families reported that child caregivers are also included in this. And I'll talk a little bit more about that as well. as an important segment that we need to focus on. And so when we think about who these men are, let's also not forget that these children, adolescents, and also young adults who are just trying to be kids, just trying to be adolescents, are also involved in the caregiving role, and Black men included. And so these individuals will not necessarily share with their teachers, right? Reasons behind homework being submitted late, reason behind showing up late for schools. Social services could be called in because they're not performing in the way that they need to, or showing up in the ways that they need to because of caregiving duties, and they have fears around divulging the stigma, right, even among their friends, of what could happen if they reveal what it is that they are actually doing. And it decreases also their ability to engage in sporting activities as well. And we know how important that is, especially for our children and young adults as they engage in their academics as well. Also, the risk of suicide in Black men, particularly young Black men. And if you add on the additional challenge of caregiving, is significant. So I think for, again, these reasons, we must pay really particularly close attention to these numbers and the needs for these children, adolescents, and young adults. Let's also not forget that there are grandparents who are caring for grandkids, and these also include grandfathers who are sometimes raising their grandkids. Yes, and also, we have to be mindful of what that challenge looks like for them. If you just think about the different generational shifts, right, that we have all undergone, whether it's social media and the challenges around that, and being a grandfather and trying to raise, whether it's a younger kid, an adolescent, teenager, you name it, and the challenges around there. And so what I'd like to draw your attention to now is just a few community engagement approaches that I've seen in the community that either help to support Black men in particular, and also dementia caregivers with a focus on Black men. And so the African American Male Wellness Agency, I think, is a wonderful example of an organization that is national, that helps to support the needs of Black men. The Black Male Wellness Day is held across the United States in a lot of major cities. We just had our day here in Columbus, Ohio, back on August 9th. And I participated as usual, and it's always a wonderful event where men's health and their health screenings are brought to the forefront. I know in Atlanta, your walk is coming up on September 20th down there in Georgia. So this is just, again, a way of bringing the services, bringing healthcare in front of Black men, getting them engaged, having follow-ups with them as well. Melanin Minded, that you see featured here, is an organization that was formed by a Black male as well, who is a former caregiver for somebody who lived with dementia, his mom, actually. And what this organization does, it's a community-based program that helps to build bridges through information and supports around dementia and dementia caregiving, including around driving programs, so helping people living with dementia safely get to different, to handle their business and the like, by training individuals to be able to recognize signs and symptoms of dementia, to address them if needed, as well. And this organization also helps to empower youth caregivers. It's led by Dr. Bashir Easter, their colleague of mine. And then also when we talk about Black men and meeting them where they are in the community, the likelihood, again, that they will raise their hands and say that I'm a caregiver, or even let their physicians know, their healthcare providers, if they have one, know that they're caregivers. We have to meet them where they are. So one great example of that, I think, is just a couple of weeks ago, I was invited to give a health talk, 7 minutes, that's it, courtside at a basketball game, in between games, about family caregiving, mental health, physical health to Black men. And so it was an opportunity to have men raise their hands and say whether or not they've had their checkup, their health checkup, their annual checkup within the last 6 months, whether or not they're a caregiver. Remind them of some things that they need to be doing for themselves as caregivers, and just, a wonderful opportunity. And this program was called Hoops for Health, which I think the name was quite fitting, or is quite fitting. Also here, just looking at some national and more local organizations, just as exemplars that help to organize around this, the Us Against Alzheimer's organization, the Alzheimer's Association, which I know is represented there, but more on the local front here in the Columbus, Ohio area. Just as an example, we have a grassroots organization called the African American Alzheimer's and Wellness Association. We also have an alliance that was founded here. So thinking about the needs of individuals in the community, the ADHOC is the acronym, and it stands for the Alliance for Diversity and Dementia for the Central Ohio Community. And what this organization is this bringing together of 3 very different groups of organizations. So we have an academic partnership with our Aging Center in the College of Nursing here at Ohio State. We have our local chapter of the Alzheimer's Association here in Central Ohio. And then this wonderful grassroots organization, the African American Alzheimer's and Wellness Association. And we came together all around meeting the needs of, or I should say, building bridges to meet the needs of all people living with dementia and their family caregivers. We host an annual brain health fair that we're in our 4th year. It's coming up next month, that we host multiple agencies around dementia and dementia caregiving and aging. We offer health screenings, including cognitive screenings, and we're able to share these opportunities with different organizations and agencies. It is held at an adult daycare facility that already has this traffic of beautiful older adults coming in and out of. And like I said, other health screenings, blood pressure, blood glucose, hemoglobin A1C, blood cholesterol are also available on site. And then last but not least, I want to just mention these as just a few examples. And I know Dr. Turner is on, and he's a presenter, and he will share about his Black male caregiver study. There's also the Black Men's Health Project, where they collect data and try to examine, assess health outcomes for Black men. The ALTA program, which is also focused on Black dementia caregivers, including Black men, where they involve where faith organizations are involved around education and support for faith-based organizations and their congregants to, do things like help ensure that church services are dementia friendly. And that's led by Dr. Fayron Epps, a great colleague of mine. And lastly, I would like to mention this logo you see down here is my program that my research team and I have developed through research. So when we talk about the importance of research, this is where you see these examples. This program called Peer to Care is a peer support program. So what this was birthed out of was the need by Black caregivers of people living with dementia specifically, sharing the fact that, for example, support groups are great, but I can't get to a support group. I can't show up at a certain time on a certain day to be able to meet with a group, but I would like to be connected with somebody who gets me. So when we talk about, I think as the previous caregiver who spoke mentioned, this notion of being able to connect with somebody who's walked that walk, this is what caregivers wanted. And so what we do is we pair our former caregivers with somebody who is, we pair our caregivers, with somebody who was a caregiver in the past for peer support. And it's 100% virtual. I will tell you that in our first iteration of testing, just on the local stage here, we had phenomenal results. We recruited individuals really quickly, which is almost unheard of in research in general, and even more so with research conducted with Black individuals. No one left the study voluntarily. We also saw movements in some of our health outcomes, which we did not expect, and really can't make anything of that because our sample size was so small. But we have submitted application to the National Institute on Aging and to support expanding the research study. But one of the things I want to say is we fought hard to get men included in this study. We did not get in this small version, but we have implemented or are planning to implement strategies to be more intentional. We came really close with our first iteration, but we are implementing strategies to be really intentional about being able to include men in our upcoming study. But again, just examples of the importance of this work that needs to be done. I also want to specifically highlight things like the need for involving organizations such as law enforcement. When you think about Black men, when you as caregivers, law enforcement, the fire department, and making sure that they are aware that there is somebody living in a home with dementia, so that if they do get a call, for example. So these are just one of the many things that we can be thinking about that can be offered to individuals. When you think about conference attendance for men, oftentimes you hear of childcare will be available, right? So also think of, how can we offer older adult care at these events? So these can allow opportunities for caregivers to be able to show up when they can, with the ability to have some sort of respite on site, along with many other things. So I will close by saying my hope, my dream, and like many of you, I pray that one day we will achieve health equity for all people in this space, particularly around caregiving, family caregiving, that is. And I thank you for your time and attention, and most importantly, for shining a bright light on this important segment of family caregivers. And I will take your questions.
Thank you. Absolutely. Thank you so much, Dr. Moss. I just have one quick question. And that was when you talked about the underreporting and the stigma about that as far as African American males are concerned, especially to kind of combat that, were you basically using the agencies that you kind of mentioned, or has there been any kind of conversation from a state governmental perspective, also how to kind of reach out to address the kind of unique problems addressing caregiving, especially involving African American men?
Yeah, so the the challenges around that we experience here in the Ohio area as well, unfortunately. And research is one of the ways that we're working hard to be able to bring forth, have Black men be able to step forward and say, yes, I'm in the caregiving role and I need support. But when we think about how we can access them, how we can get in front of them, research is not always the best way, right? So when we think about the agencies, as for example, that I mentioned, like the African American Male Wellness Organization. So when men come forward to these large festivals and events where you can catch them courtside to, talk to them about their health in general, and you can ask them specifically, are you caregiving? I think it's a great opportunity to ease into the conversation, if you will. And then I think there's this whole notion of the benefit of it being done by another Black male, and helping to ease that comfort of individuals being able to express that, yes, I am in this caregiving role, and yes, I do need help, and not feeling guilty about that.
Thank you so much. Any other questions from the panel? Dr. Moss, thank you so much for bringing this to our attention. It's an area it's further research and also articulation as far as this state is concerned. Thank you for joining us.
Thank you.
Absolutely. Let's see. Do we have Garrett Davis on? Okay, we'll see if we can come back to him. I see that we have Beverly Berry, Director of Diversity, Equity, and Inclusion Engagement for Alzheimer's Association. Mr. Berry? Oh, I'm sorry, Barry, you ready?
I
Ms.
am.
Berry?
Good
Yeah, thank
afternoon,
you.
everybody. I'm going to pull my slides up here. Share my screen. All right. Well, good afternoon again. Senator Harold Jones, Senate State Committee, community partners, and to my amazing colleagues and volunteers from the Alzheimer's Association Georgia chapter. I'm so happy to be here, and thank you for the opportunity to share insights on the needs and concerns of African American caregivers. Again, my name is Beverly Berry. I'm the Director of Diversity, Equity, and Inclusion at the Alzheimer's Association National Office. You know, when we talk about caregiving, we are not simply discussing logistics. We are talking about really an invisible force, the backbone of our health system, carrying an enormous responsibility with little recognition or support. And so for today's conversation, I'd really like to reference our 2021 special report on race, ethnicity, and Alzheimer's and dementia. I know that this is a 2021 report, but this is still very relevant today, and it still helps to guide a lot of our work in community. And so what I'd like to also share here, and this is the link to this report and our current facts and figures report that we have listed as well. Here's what we did for this facts and figures special report around racial, ethnic attitudes and expression regarding Alzheimer's and dementia. Respondents were asked about access to care and support services, trust in providers, healthcare systems, participating in clinical trials and research, and caregiver experiences. This was the Alzheimer's first survey to really ask deeply and investigate the experiences of diverse caregivers. This research provides the foundation from what I'll share with you today about the realities faced by African American caregivers. So when we look at the landscape of caregivers, we know that there are more than 11 million Americans that are providing unpaid caregiving for someone living with Alzheimer's or another form of dementia. African American families are disproportionately represented in these numbers, as we know that they're twice as likely to step into caregiving roles compared to white caregivers, often beginning earlier in the disease processes and stages, continuing longer into advanced stages. This means African Americans are providing more hours per week for years and often more with fewer resources to rely on. So when we look at this data here, again, we see when we report across multiple ethnicities and races, we see that 50% of African Americans report that discrimination is also a barrier when it comes to seeking care for a loved one. And so this just really reflects the systemic barriers that are within the health systems that we need to address to look further and deeper into cultural relevance and cultural humility in these spaces to be able to alleviate this type of discrimination and barrier while seeking care. We know that Black Americans are 2 times as likely to have Alzheimer's or another form of dementia. We've already highlighted that have experienced discrimination while seeking care. And then another note to mention is that nearly 2/3 believe medical research is biased against people of color. Also in this report, we noted that looking at women and Alzheimer's disease, in the US, more than 10 million women are either living with the disease or caring for someone who has it. Over 60% of Alzheimer's and dementia caregivers are women, and almost 2/3 of Americans living with Alzheimer's are women. And so when you add in race and ethnicity, you can see that there is a huge burden that's carried by Black women in this space as it relates to Alzheimer's and dementia, but also around their caregiving needs as well. So being able to do more and in supporting women in this space, as well as the many other caregivers that are providing care and support for their loved ones that are navigating this devastating disease. We looked across dementia caregiving demands. So when we look across the gamut, and I know we're specifically focused on African American caregiving, but even looking across multiple communities that are disproportionately affected by this disease, we see that greater care demands, less use of outside help, and even greater depression compared to white American caregivers are a reality for communities that are underrepresented and disproportionately affected by this disease. We know that in caregiving, some people may have to take off work more frequently or even leave their jobs altogether. So it also places a financial strain on families as well that can affect them over time. So, when a caregiver has to leave their job, they're also leaving benefits, they're leaving retirement. And so there is a heavy strain and burden when it comes to Black Americans and even other populations that are underrepresented and under-resourced in this space. So in looking at some of these statistics as it relates to Alzheimer's and dementia and caregiving, there are a few calls to action because what we're really looking for in this space is equity across the board. So whether it's in the caregiving journey and caregiving support, but also in access to care and support, early and timely diagnosis to help better plan as caregivers in this space so that their journey is better supported and having a more timely and accurate diagnosis. So these are just a few calls to action that we're working towards and really looking to work with other partners across the nation and even in Georgia to really accomplish our vision of a world without Alzheimer's and all of the dementia. So one is to conduct, promote, and support multi-level health disparities, research focused on all dementia and caregiving. So really, looking at Alzheimer's, but also looking at the multiple types of dementia that exist and that affect underrepresented and under-resourced communities disproportionately. And also tying that into caregiving as well. What is that caregiving journey like? What are the resources that are needed? And really looking to the lived experience of these individuals and how we can help support them. Increasing diversity in health systems and health-related institutions. As the data showed that more than 50% of African Americans expressed being discriminated against while seeking care for their loved one. And so it's a call to action to really look at systemic barriers that create challenges for seeking care for their loved ones. So cultural relevance, cultural humility, and just really taking the time to learn and listen from various communities that are impacted by this disease. And I've already spoke about enhancing cultural competence in dementia research and care. So really having more diversity in that space to better understand what are the needs and how do we get more people involved in research to better understand caregiving and this disease as a whole. And then also participating in engagement with national and local organizations to build trust and agency to really be seen as a trustworthy organization to work with. We're all represented in our various roles in our organizations, but we're one person, we're one organization. And when we're working together to collaborate, to really address the concerns and needs of communities and caregivers, we can go so much further together. And so that participatory engagement is really the key to us better supporting our caregivers around Alzheimer's and dementia. And this is just our roadmap and what we're looking to do. The power of collaborative partnership, building that community-based participatory principles that's at the heart of this all is building trust. You know, each community has its own needs, its own assets, its own culture, and even its own social structure. So really getting to the heart of that to understand what's needed, mobilizing communities around this issue, and also even once we have these resources that are available, that we're making them easily accessible to be able to use and implement in real time and with the situations that they're having to navigate as it relates to Alzheimer's and dementia. And speaking of national partnerships, these are just some of the partners that we're working with to really ensure that this message around recognizing the warning signs, understanding the disease, being able to provide support to caregivers and communities is really important. And through our 40 plus national partners is what we're doing, and just happy to be able to help support this work in any way that we can. And so this ends my presentation. I always end with our helpline to be able to provide resources. And I'll take any questions that you all have. Thank you so much for the opportunity.
Ms. Berry, thank you so much for your presentation. I do have one question. What spurred the understanding of the association's need to look at the diversity for caregivers?
I'm sorry, can you repeat that again? I'm sorry, I didn't quite hear it.
I'm sorry, I need to speak up a little bit. I wanted to say what spurred the understanding for the association's need to look at the diversity and caregiving?
Yeah. So, you know, I think it's the data that really speaks to um, our need to really look at diversity. The numbers don't lie. When we look at the number of communities that are under-resourced and underserved when it comes to this disease, and working with our partners, and even listening to them to hold us accountable in what's missing in communities and what's needed. I think that also presents the power of partnership to understand and help to bridge gaps in areas that we may not be well versed in, but really collaborating with other community partner organizations to help bridge that gap. And so understanding those needs from diverse communities to achieve health equity is just really important. And so the more that we do this, that we listen, that we provide opportunities to hear feedback from the community, it helps to guide our steps better in how we're able to support, especially as we move forward in this space of treatments and just being a good steward of this work and building trustworthiness within our communities.
We have one more question.
A little bit on, we were talking about discrimination, a lot of you mentioned discrimination in terms of how diagnoses were given out, or even, I guess, being seen by doctors. How does that present itself? Or how have they discussed? Can you hear me, Dr.
I
Berry?
can hear you now. Thank you.
You know you hear me. Okay. All right. So I wanted you to elaborate a little bit discrimination in healthcare and how that presents itself when caregivers are trying to get help for their loved ones with Alzheimer's.
Yeah, it's a great question. You know, discrimination can be reflected in a healthcare setting when families feel like their needs are not being met. For instance, you may have a family that's coming in that's expressing a concern about their loved ones, about changes in their loved one's memory or thinking, and it's not taken seriously. It can be brushed off, or that I've heard even individuals say that they have experienced not being able to access all of the resources that are available in different spaces. So it can present itself in different ways, but also just being able to recognize it and encouraging those in communities to be an advocate for their loved one. That when you feel like your needs are not being met or that your concerns are not being addressed, to elevate that they can feel empowered to elevate that up to leadership, so that we can address that those needs can be addressed. And that's even some of the work that we do in our health systems work, and making sure that we're educating health systems about the nuances around this disease, in spaces where we can provide cultural relevance and cultural competence to make sure that those that are under-resourced and need this information most can have access to it.
Have you ever heard of an instance where a family member felt that resources were actually being withheld, or education or knowledge was being withheld?
Yes, I have. We do our team, our diversity, equity, and inclusion team. We do work across the country. We're doing presentations alongside our Chief DEI Officer, Dr. Carl Hill. And then just in being in some of those local communities, and you share this data, you do hear, you get a mouthful from being in the community and understanding what's going on more locally, about feeling like resources and support may be withheld in healthcare settings. And so that's where the work comes in, and working with health systems to be sure that they're trustworthy and that we're working together to provide these resources. So yes, it happens.
Thank you.
Ms. Barry, we want to thank you so much for joining us today and talking about such an important issue. That's why we had it on here. So we do want to thank you for joining us, and we appreciate all your comments.
Thank you. Thank you for having me.
Absolutely. Next up, we have Dr. Robert Turner, Adjunct Associate Professor of Clinical Research and Leadership at George Washington University. Dr. Turner.
All right, thank you. And I'm going to share my screen now. Can you all hear me?
Yes.
Okay, great. Let me get this up and running for you. All right. First of all, I'd like to thank you again. I reiterate the thanks that all of my other colleagues have said for having me participate in this. And I hope that at this late hour, I hope that I'll ask for your apologies if I'm redundant on some of the excellent information that was provided to you already by my colleagues like Dr. Karen Moss and Beverly Berry and so many others. And so I'll do my very best to be very laser focused in what we'll talk about today. I want to also just share that you can see at the bottom of the screen here on this particular slide is my email address. I recently moved from George Washington University over to Duke University in the School of Medicine. But I think in my role today, it would probably be helpful for you to understand a little bit about who I am and how I wound up being here today. But as you can see, I'm the Associate Professor in the Department of Population Health Sciences, and I'm also in the Duke Aging Center. I'm one of the co-leads for the Duke UNC Alzheimer's Disease Research Center in their core, which is outreach, recruitment, and engagement. I'm also the founding director of the Black Men's Brain Health Initiative, and we have a national conference every year in partnership with the Alzheimer's Association as well as the NFL Alumni Association. And that tie-in is because I have a background as a former professional athlete. I played professional football for 4 years through the Canadian Football League, the old USFL, and I finished up briefly with the NFL, which drove me to start looking at and being concerned with brain health. And I think in particularly what's important here for this conversation is my background as a caregiver for my dad, who recently passed from Alzheimer's dementia back in October. And I also cared for my mom at the same time with a little bit of overlap for about a year as she was dealing with a chronic kidney condition. And so when we talk about Black men's brain health or Black men's health and caregiving, I think it's very important for us to think about, and we've heard statistics all throughout the day about people's different populations. But what's most important when you think about Black men's health or men's health in general is think about their health and the position that they are in when they are then tasked to provide care for someone. And what's striking on this slide here is I just want to point out that 21 million Black men in the U.S. Face worse health outcomes than any other racial group. Right? Some of these factors that are contributing to this are limited affordability of healthcare, poor health education, cultural barriers, poverty, tailored services, discrimination that we just talked about. But I also want to shed light a little bit on in thinking about men. Is how men understand what it means to be a man. What is their definition of a man? And as you probably all, I know that the household that I came from, I remember seeing that my grandfather, he was the rock. He was steady. You never heard him complain about anything. He just got up and go to work every day. So we never knew about what his health was like. But I also want to focus in that Black men have higher death rates than women for all causes leading to death. But what's particularly interesting in this conversation that we're going to talk about, and I'm going to provide some information, some results from the Black men's caregiver study that I have been ongoing and has been funded by the National Institute on Aging. But you'll see up in the top right corner it says that that particularly for African American Black individuals, we only comprise of 5% of all Alzheimer's and dementia related research. And so that's across the country, we only make up about 5%. We don't really understand how all these risk factors and early diagnosis and all these other things really impact Black Americans nearly as much. And so that's why the Alzheimer's Association makes a strong push to diversify as many people who are participating in the research as possible. But what's stark about that 5% is that Black men only comprise of 25% of that 5%. So Black women are 75% more likely to be in research than Black men are. And so we have to think about how things like hypertension and how smoking cigarettes, alcohol use, the high percentage of obesity, how do all of those things factor into when we talk about caregivers who have to take care of their own health first before they can really be in a role to care for other people? All right. Also, I'm sorry here. This is just another slide to go back. But what's most noteworthy on this particular slide is that you'll see up in the upper left hand corner, it says life expectancy for Black men. There it says 70.7 years. But since COVID has really had such a stark impact on the Black community, the Black male life expectancy has reduced by 3 years. And it's now, according to the CDC, 67.7 years, right? But we also want to look at in terms of men and overall men in their health, right? Men are at greater risk of death in every other categories compared to women. 1.6 times mortality for all cause, 1.8 for diseases of the heart, 1.4 for cancers, 2.4 for accidents. 33% of men report having not seeing the physician on a regular basis, and almost a quarter of men have not seen a physician in the last 12 months. And sadly, in every one of these statistical categories, Black men fare even worse than the general overall male population in America. All right. I'm not going to go over too many other statistics here. We know that, what it says about Alzheimer's. But the thing that I do want to point out, because people ask about this all the time, but genetic factors do not appear to account for the greater prevalence of Alzheimer's and dementia within the Black community. So that means that there are a number of maybe social factors, environmental factors, behavioral factors that may factor into this. And that's why having individuals involved from all different backgrounds being involved in research is so vitally important. So we can understand how these different factors impact different populations accordingly. And what is caregiving? So we just want to make sure that we are all on the same page. We've had lots of different things and people have alluded to this, but I just want to point out that really it's when people often need assistance with one or more daily activities. And that's why, we could be looking from everything from a very mild cognitive impairment until full on dementia where people can't do anything for themselves, right? But we're talking about things including like bath and dress, those kinds of things. And then you're looking at instrumental activities of daily living, like paying people's bills, going shopping, using transportation. Right. And we can see here from a slide from the Alzheimer's Association, these are the types of things that people need most help with, getting in and out of bed and out of chairs. And how would that affect you as a caregiver? If you don't know how to do it properly, you can injure yourself. Dressing people, bathing, shower, feeding, helping people get it from in and out of toilets. And we want to talk about, when we think about, in some respects, that whole idea of masculinity, caregiving. I remember one of the biggest challenges that I had was my mom fell one time in the bathroom, and she had a heart device on her externally, and she got tangled up in it, and it just really twisted everything. And so the only way we could get it off of her at that point in time is she was in the bathroom in a very small space. I had to help her take off her nightgown and take off her the device for her heart monitoring device. And it was quite embarrassing for her to have her son have to play that role. And for me, I had to just show how much I cared and I loved her and cover her back up as much as quickly as possible. But that was a real, I guess, watershed moment for both of us, where it was quite obvious that as her caregiver and her son, we had flipped roles. So when we think about men who are giving care, Black men in particular, those ideas and understanding of those role and expectations are very important. But I want to highlight here that nearly 45% of Black husbands provide for care for their wives, and another 30% of Black sons are involved with caregiving efforts. They're less likely, while the research says is they're less likely to ask for help, to vocalize that they need help. One, because as we talk about, my grandfather, you are always in your mind, you're supposed to be the strong one. So who am I to be asking for help? 30 to 40% of informal caregivers are elderly husbands, are often caring for spouses experiencing dementia. Just want to focus on here really in terms of, we haven't heard much about this today, but we know very much in the Black and brown communities, Hispanic communities, and often in white communities as well. But caregiving is often in the Black community is depicted as part of culture or family history that has been passed on for generations. Therefore, caregiving comes naturally. It's nothing new. And here's a quote from a study that was published in 2014. And it says that, it just comes naturally, that it's been in our family for so long. We have had a lot of caregivers, a lot of folks wanted to help, waited to help on a number of years to overlook the role. And, so it's nothing new here. And then we talk about spirituality and faith. That's really important within the community as well. They're often part of the context by which people understand and experience dementia as a source of healing and strength, even though it's really, really challenging. But people look to, and we heard it earlier, but just thanking God for so much support. But here we see a statement that says, I believe you can be healed through faith, but you must first have faith in yourself. I don't think anybody can pray and heal you unless you have faith. I believe you have faith, but you have to have faith before the illness, cognitive impairment, Alzheimer's here, it comes on, because if you can't remember, you can't ask God for forgiveness and to give you faith. And then also a second one, it says, I just put my trust in the good Lord. He will give you strength. And when I'm tired and frustrated, I pray to God to give me the strength to deal with her. So we want to acknowledge that. The other thing is, of all the data, it shows that Black male caregivers, compared to any population, any other population in America, as a group, they most likely to feel burdened in their role. So they say that they have higher levels of stress than anyone else. Black men, caregivers are likely to report that they are 3.3 times more likely to experience financial burden than other caregivers, right? And then Black caregivers as a whole are often they're tasked with doing extra hours of caregiving responsibilities, including helping recipients with ADLs. And this might come from the low usage or lack of availability of respite care, particularly out in rural areas, as we think about in Georgia. So these are all factors that we have to consider when we think about these men providing care for a loved one that has a form of memory loss, right? But in the literature, it discusses, particularly for Black men, culture and gender expectations, society's perspective of caregiving historically being women's work, the lack of support networks, reluctance to use formal or informal support systems due to lack of representations. Oftentimes we've heard people want to go to doctors that look like them, that have similar cultural background, racial experiences. And if you feel like there's no place to turn where you can be vulnerable to open up because you don't see people who look like you, then you just start to carry that load on your own. Okay. And then social stigma, often caregivers of a person with dementia face discrimination challenges navigating the healthcare system, don't feel that that system really is designed for them. I've heard lots of men talk about that. I've had men tell me they don't go to the doctors because all they ever hear when they get there is bad news. And then it's very expensive. And they feel like the doctors don't really pay attention to their particular unique needs. And then there's also this thing that we talked about before, stress, the role strain. Balancing caregiver responsibilities with other commitments results in high stress levels and times and in financial strain. So they all tend to, Black men, and when they are in research, they tend to, the numbers in the data supports that it's a heavier burden on them in particular. So I'm just going to briefly go over, my study here and how we set it up and some of the things that we learned about it. But really, our research question was, what is the effect of dementia caregiving stress on cognitive function in adult Black males? Right? And participants, what they did is they completed a survey about their physical and mental health, right? Neurocognitive health. And they completed a series of neurocognitive assessments as well as we collected saliva samples from them. And so what we did is when we did this particular study, it was right as COVID was taking over and it prevented us from meeting in person. So we conducted the whole study for 2 to 3 hours remotely. And participants were compensated $125 for their time. And we recruited in particular 40 Black men in the Washington, D.C. area who were age 30 and above. And the comparison group were Black men who did not provide health care for a loved one with dementia or other kind of memory impairment. And these were non-skilled laborers. These were basically loved ones that were looking after one another. And then the group that we were looking at, this was 40 Black men who did provide care. And so what we had to do in order to do this, one of the biggest factors that we had was that could we actually go out and recruit these men? Because when we started talking to men working in the community, one of the big things that we asked people, had you ever been involved in a research study before of any kind? And overwhelmingly, many of them said no. And most people thought it was they hadn't been involved in the study because of trust and different things like that and Tuskegee. But the number one answer that we got when we asked people was, why hadn't you ever been involved in a study? And they said overwhelmingly is because we've never been asked. right? So one part is reaching out and asking people and then being able to educate them. And so that's why we we had to create a number of different marketing materials to be able to reach out to the community, videos, FAQs, frequently asked questions. We had, different types of flyers, working with community members to tell us how to best position the messaging and the education that was necessary to get these men involved with this. Right. And so we also then took a faith engagement initiative approach within this, working with some of the local churches. And our goal was to be able to build these relationships. We went on a listening tour with faith leaders. The faith leaders were asked to participate in the stories, in the study themselves, because we felt that that was very important, that they were going to take this back to the community and ask the members of their church to be involved. They could talk from firsthand experience as well as being in there. And then they helped us figure out how to make the community aware of the study and deliver. And we're working now to deliver the results back through the faith engagement initiative here with this. So here's an example of, one of the flyers that we put together to provide enough information. Interesting enough, this is the first one of the earlier iterations of our study. What we learned from being out when we were able to go back out to the community once COVID subsided, we learned very much because of the history that Washington, D.C. had with George Washington University and doing research, helicopter research, taking from the community, not giving back to it, as well as people having a very negative connotation around the word study. We were told that we would be much better off if we replaced the word study, if we said that it was a project or a program to help us better understand the needs of men within the communities. And so that's really kind of what we wound up focusing on. But I want to highlight as I close here, basically the three most important things that we found in our research to date. And we're still data mining and doing have a number of different studies that we're reporting on and writing up in manuscripts, and we'll be able to take back to the community. But basically what we did find is not surprising, but it helps us get insight as to how we might want to be able to address men, how we might want to be able to come and provide, create interventions that help them in particular. But in our sample of non-Hispanic Black men who were unpaid caregivers compared to non-caregivers, these caregivers they reported much higher rates of depressive symptomology. Right. So they were basically, we were saying that, hey, you know what, this is a hard and heavy road. And they were dealing with depression, and many of them weren't really getting any help or asking out and reaching for help with some of the depressive symptomology they had. They had greater sleep dysfunction, as you might well think. They were having much harder time with many different areas of sleeping. And what's really important here to think about in this instance in particular is that other research has shown that I've done, and it's been published, and we found it within our group as well, is that many Black men have a higher prevalence of sleep apnea. So they're already dealing with sleep concerns and sleep problems. And then before they even move into that caregiver role, and then it becomes even more disrupted because of the stress that they're dealing with. And then the other thing that we've seen was that really their working memory, their working verbal short-term and working memory, they had trouble finding words, had trouble really expressing what was going on. And there was some frustration around that. And that raised an even higher level of anxiety, saying, am I, somehow or another is exhibiting early stages of dementia, Alzheimer's, memory loss. But again, helping them to try to understand when you're depressed and you're sleep deprived, it is going to be really hard to look and find your word and, have your memory difficulties. So I just want to stop there and thank you again for allowing me to be here. But I really want to just state again, as others, the caregivers here have talked about before, in my caregiving journey and my research that has really, driven me towards this, is that I wouldn't even say there was a labor of love. It was probably the most difficult thing that I've ever had to do in my life. But I can say at the same time, it was definitely the most rewarding thing that I've ever done in my life. And I just think that I want to just, thank the Alzheimer's Association when I reach out to them and others who has supported me on that journey to really to love and care for my dad and my mom the way that I was able to do over the last couple of years. And with that, I'll say thank you so much for allowing me to be here.
Thank you, Dr. Turner. Let me ask one quick question, actually, two. You mentioned about the lack of African American males within the clinical trials, and one of my questions was going to be, was that the lack of outreach or refusal to participate? You answered that by saying it was a lack of outreach. So my question now is, once that outreach was taking place, did the participation rates go up? Were they comparable to other groups once that outreach did take place?
Well, so in my study, again, my study was only focused on Black men. So, but one of the things that we did set out to do was to show, the Alzheimer's Association, not the Alzheimer's Association per se, but the NIH who funded this project, that Black men were actually willing to and enthusiastic about being involved in biomedical research, particularly around this area of Alzheimer's and Alzheimer's dementia and caregiving. So the answer to your question is, yes, they are very willing. We have found that Black men, and again, I have a Black Men's Brain Health Conference. We get over 2,000 people involved with that conference every year. I can say emphatically that men are very much interested in being involved and being part of research, asking these questions, getting answers. They want to be educated by this. But I will say this, you can't use the same methods with other populations that you do working with them. You really have to show them that, in one instance, you as a Black man doing the research, I got to show them that I'm willing to be vulnerable because I'm asking them to be vulnerable, right? And so it's about building relationships. It's about, and what I've heard from people say to me all along is, it may be about trust, it may not be about trust, but what it really is I don't know who you are. You're asking me to trust you or give you, so, and in some instances, our saliva, you want us to get into my brain, talk about my trauma and my stress, but I need to know that you're going to be here for the long haul. So if we do the work, they do want to be involved with the studies.
Absolutely. Thank you so much. And one last question. You had mentioned Black caregivers are tasked with extra hours of caregiving. Explain that for me.
Well, what it means is essentially, and we've had people talk about this today, but if you think about one, it's expensive to have a home health aide, right? And so if that is a financial burden with you already, we saw that in an example that the average household income for someone that's providing care, informal caregiving, is about $50. If you don't have at least that, then it may be really difficult. If your social network can't help you because, as we've talked about, in an example, the prevalence rates are higher in the Black community, right? So, and women are more likely to have Alzheimer's. So you might have fewer people to actually call on to be able to support you, as well as you're not really used to asking for people to give you help. All of those things contribute to why you would see that they're asked, then they're tasked to do so much more. One, because maybe they just don't feel comfortable asking. Two, they may not have anyone to ask. Three, they might not be able to afford to ask to pay for the help.
Thank you. Any other questions from the panel? Dr. Turner, I want to thank you so much for taking time out of your day to join us today. Great information. Thank you so much.
Thank you. Appreciate it.
Thank you, everybody, for coming out today. We're now going to open up for public comment. We do have one person that signed up, and that is Miss Terry Holmes. Yeah, come on. Do you still want to speak? Yeah, come on up. Oh, I see where I made a mistake. Yeah, it's Terry. I got you.
So my name is Katrina Holmes, and this is my brother, Terry Holmes. And in 2015, our dad had a massive stroke that nearly took his life. He was, of course, African-American male, 66 years old, had not retired as of yet. We had big plans about what his life would look like after retirement. Our mother had already retired, but we found ourselves as instant family caregivers like everyone else, and not knowing. I have a master's degree in industrial organizational psychology, so training and development is my passion. I also had 17 and a half years as a pediatric nursing assistant working with families who were caring for children that were medically fragile at a place called Southwest Christian Care in Union City, Georgia. And so with that, I knew that training was essential for family caregivers. Again, working in healthcare, knowing and training and development, not having the skill set to actually take care of our father. So we're looking at a journey that has spanned over almost 10 years. Actually, September the 28th will actually be 10 years in family caregiving. And this is 24 hours a day, 7 days a week. He had the massive stroke. It included right side weakness. He can no longer, has expressive aphasia, requires ADL care every single day, but also speech, occupational therapy, and physical therapy. So one of the challenges that we had upon discharge from a rehabilitation hospital was not being educated on knowing how Medicare actually works. So one of the things that I want to present for your consideration is to reevaluate Medicare, and I have a list of things. Hold on. See? Okay. So patients are currently spending too many days in the hospital and too few days in rehab despite Medicare coverage. Medicare coverage is up to 60 days per benefit period, plus 90 regular days, 60 lifetime reserve days in extreme cases. Skilled nursing, we have up to 100 days per benefit period, just first 20 days, fully covered days 2100 with co-insurance. Psychiatric care, and this is for all persons with different various needs of care. So psychiatric care, acute inpatient psychiatric hospital, up to 190 lifetime days. To the problem, hospitals are more expensive per day than rehab, yet patients often stay in acute care beds longer than needed. Rehab coverage, while capped at 100 days, is often insufficient for full recovery, leading to incomplete recovery and potential readmission. So the challenge here is when a person is released from a rehab facility, they may be released too soon and they come back to the families not fully functioning or have limited abilities, but through more time in the rehab facility, it will lessen the care or the burden on the caregiver. Okay. Psychiatric patients face lifetime limits, 190 days, that may be inadequate for complex chronic conditions. So the solution: shorten hospital stays to medically necessary acute care. Number two, extend rehab coverage based on patient needs, allowing patients to fully recover functional abilities. Number three, tie psychiatric coverage to clinical need, not arbitrary lifetime limits. The benefits: cost savings, shifting high-cost hospital days to rehab stays, 1,000 to 1,800 per day per patient. Better patient outcomes, faster functional recovery, low admission, improve quality of life. Family caregiver support. Rehab prepares patients to return home safely, reducing caregiver stress. Families receive training and guidance for home care. And one of the things that our family did as a result of not having that training is we started the Holmes Family Online Family Caregiver Training Academy to address that needs. And it's an online, because we are still caregivers. We're part of a extensive family caregiving team with all of our family members being involved, working with our dad, but then also formerly working with our grandmother who has also who's transitioned. But that was one of the ways in which we attempted to find a solution, not just for ourselves, but for other people. So the bottom line: optimize healthcare resources. Hospitals free up beds for acute patients. Rehab facilities deliver therapy efficiently. By aligning Medicare coverage with actual patient needs, shorter hospital stays, longer rehab, and flexible psychiatric coverage, patients recover fully, families are supported, and Medicare saves money. That's it. Thank you.
I'll just add, like Katrina is really a great researcher. So if you all need this report, she can email it. But I just wanted to echo one of the points that I heard spoken here today. The point was that at the point, well, in our case, one of the really impactful points where we could have been given information to improve my father's health outcome, we weren't given that, and that was in the hospital. So there's a point in time when the social worker in the hospital meets with the family. They create a plan of care. During that conversation, that would have been the perfect time to introduce a lot of these resources in terms of where we could have gone to get more information, to become better trained, to improve the outcome for my father. Then the research that Katrina did on the insurance, we didn't have that conversation either. Nobody really explained to us the way that the insurance worked. So we made some decisions that might not have been the best decisions, not understanding fully how insurance would have impacted my father's outcome. So that's one of the things that we would like to propose for consideration. Aligning ourselves, or creating a policy wherein the hospitals and the social worker is required to include some sort of training recommendation for the family before they leave the hospital. So we think that would be really good. Then in addition to that, I think that there's another opportunity for us to be able to augment the employment benefits packages with the company. So I've heard, a lot of the presenters talking about the tie-in between taking care caregivers and then the workforce. So for instance, I work with E-Trade. We have family medical leave that they can give you. And then we have like a month of care that you can provide, that they will give you to be paid and provide care for a loved one. The thing that's missing in that is education. Again, so they would send you home to provide care for a loved one, but not really give you a way of fully understanding how to properly care for that loved one. So I think there's also an opportunity to create a policy that aligns itself with corporate America to include this educational piece that we're discovering is very important. So that's it.
Absolutely. Thank you so much. I agree on the rehab issue, because that is something, because patient is going to do better rehabbing at the rehab facility. When you bring your loved one home and they say, okay, you can do these exercises with them, they're not going to respond to you the same way they respond at the rehab facility. It just didn't work that way. And the bad thing about it is they know that they're not going to respond that way. And sometimes you can bring up people to come into your house to help with that, but because they're at that kind of safe place in the home, they're still going to be pushing back not to do the rehab. If they were at that facility, you can push them more to actually do that. So I agree that that's a huge issue. Sending them home a little bit too early from the rehab situation, although they will be in the hospital a lot longer, but then the rehab, they're not there in the hospital, they're just laying there, but the rehab is not getting as much attention.
Right. And that's where reevaluating the Medicare policy would be essential, because to my understanding, my research, that you get at least 1 to 150 days of hospital stays. Okay, that's on policy. I think it's on a Medicare.gov website. Somebody can fact check that. But then when it comes to the rehab days, it's less. And so basically, from my research, when Medicare was established in 1965, the emphasis was on hospital stays, like more hospital stays, thinking that people would rehab in a shorter time. But what has happened over the time, so we discovered and talked about the centenarians. We're living longer. We have greater technology. We have greater advancements in medications and things of that nature. So people are needing less hospital stays, because when you go to the hospital, you might be in there five days and you're out of here. But when it comes to rehab, it may be 1 to 20 days that Medicare is currently paying for, and then there is some type of co-insurance that takes place at the 21st day, and then up to I think 100 days, the Medicare pays, and then after that, I think it's co-insurance, and then after that, families are looking to pay for all of the care, which is it's understandable, but the policy should be reversed where we look at more shorter days in the hospital, longer days in the rehab, because people are living with chronic challenges that are then a true burden on the families who are actually caring for them. When in rehab, they can actually get the occupational therapy, the physical therapy, the speech that is really necessary for them when they come back home, that they are a little bit more independent than fully dependent.
Absolutely. Thank you so much for your presentation. Yes, ma'am. Go ahead. Okay, go ahead. Sure.
I invited Heather Peck, who's a caregiver that we've crossed paths, and she's going to share her story with you.
Okay, thank you.
Hi, my name is Heather Peck, and I'm a caregiver for my mother that has dementia. Just a little background about me. I have been married for 25 years, and my husband and I have 5 children. Our oldest 2 are our biological kids, and they are 23 and 22 years old. About 13 years ago, we adopted 3 kids from foster care, and they are 20, 18, and 17 years old now. My father passed away about 5 years ago, and as time went on, it became apparent that my mom was not going to be able to continue to live in their home. She fell victim to scammers who stole thousands of dollars from her. There were several little things that made us realize something just wasn't right. She would leave the stove on, she ran into the garage door with the car, and sometimes she would forget to eat all day, and she forgot to take care of the dog. To be honest, I think we all knew for a few years before my dad even passed that something was off with mom's memory. But honestly, it's a hard conversation to have, and we all just made excuses instead of actually discussing it. A little over 3 years ago, we brought mom to live with us here in Augusta. At first, everything was good, but that quickly changed as we started to see what was really going on with her behaviors. I realized we couldn't leave her home alone, and she did not need to be driving anymore. She needed supervision with everything. She needed help with medicine, her bills, her laundry, fixing meals, remembering to eat and drink. She needed help with all of her daily activities. As time progressed, she was starting to wander around the house at night. We would find her fully dressed, shoes on. She had her purse in hand, and she was going somewhere on a trip. Luckily for us at the time, my older boys were home and were up, and so they were able to stop her from leaving the house. It took my entire family's help to keep her safe 24 hours a day. But as the years went on, the kids grew up and have moved on to start their lives. So the caretaking has gotten harder on me. If I get 2 to 3 hours of sleep at night, I consider that to be a good night. My hair was and is falling out by the handfuls because of all the stress of it all. My husband and I joked that when mom first came to stay with us, I was only taking 1 allergy pill a day, and now I'm taking 12 pills a day. I'm exhausted and not really realizing it. I have withdrawn from all activities that I used to enjoy. It was taking everything I had to keep her safe, and my own health is going down as I could not seem to ever find the balance with all the stress of being a caregiver. Then on our drive to Chick-fil-A, we noticed a building being built. We went to Chick-fil-A more than I'd like to admit, but I was exhausted. Finally, a sign went up on this new building, and it was called Via Cognitive Health. Of course, I looked it up online in the middle of the night after I put mom back to sleep. It took me probably 3 months of reading about VIA for me to say something to my husband. He thought we should go check this place out. He was sure they would be able to help mom and maybe I could get a little break. But honestly, the guilt I felt was so overwhelming. If I had her come to VIA's day program, then I was a failure. I wasn't a good daughter because I couldn't handle taking care of her. So finally, one day, my husband and I were driving somewhere. I don't remember where we were headed. We were probably going to Chick-fil-A again. But we had to go by VIA, and so he turned into the parking lot. I remember the feeling of pure panic when he pulled in and he parked, and he said, "Come on, we're going in." And I remember thinking, we don't have an appointment. This isn't how you're supposed to do things. We can't do this. And he said, "We're going." And I said, I knew that if I didn't walk in the doors then, I never would. Walking in those doors was the best thing I have done for me, my mom, and my family. We were greeted by the nicest people, and they gave us a tour and talked to us about what all VIA had to offer for mom. Mom started VIA's day program in December, and the first change we did notice in her was she was sleeping better. And that meant we all were sleeping better. I started coming to the Lunch and Learn programs VIA offers monthly to help me learn all about dementia and brain health. I attended the Care Partner Support Group meeting lunches and lunches that were for care partners of the members that attended VIA's day program. I quickly found I've quickly found people that were just like me. I wasn't alone anymore. I could talk to people that were going through exactly what I was going through. I was able to talk about mom shadowing me, how it was almost impossible for me to do anything at home without her right under my feet. A couple of times I would have to stop to go back into a room and I would step on her toes because she followed that close. And if I didn't shut the door to go to the bathroom, she was in there with me. Like it's stressful. So I found by going to VIA, I found people that have been and they're going through all of this, and we would encourage each other and we would help each other and give tips and ideas on just how to make it through another day. Through VIA, I also found resources in our community that I did not know existed. Primary doctors didn't help at all. They look her over, but they don't have any clue on the resources that are going on. But VIA did. VIA helped me. And now mom has an appointment at the Georgia Memory Net Care to get an assessment. It's an 8-month wait to get in there. And it is what it is. She's going to go to the appointment in February or March, something like that. My husband and I spent a Saturday in June here, at one of the campuses of Augusta, but at the Brain Health Symposium. And I would have never known about it if it weren't for VIA. They had so much information at this Brain Health Symposium and all of the resources. It was very informative. Through all of that, I have learned through all these resources that I'm definitely in caregiver burnout. Mom's dementia is progressing and it's getting harder on us to keep her safe. We're now down to only one child at home, and the weight of caregiving is affecting us all. So this past week, I had to make the extremely difficult decision and place mom in a memory care unit at an assisted living facility. The financial burden is overwhelming. Because we sold her house, she has enough money to stay there for about 5 years. I'm not sure what we're going to do when the money runs out. Other than her memory, her physical health is great. She's going to outlive everybody, I think. My decision to place her in the facility was the hardest and most selfish thing I have ever done, because I had to put my needs first. My health is going downhill, but because of all the resources I have found through VIA, I'm working through the guilt, and I see that because I wasn't able to take care of myself, that I can't take care of her. I wish I would have known about VIA and all of the resources that are available here in our community. I'm really glad that VIA moved to Washington Road, so I would pass it on my way to Chick-fil-A. I don't know where we would be. I know I probably wouldn't have any hair if I hadn't found VIA back 8-9 months ago. It's people need to know what's available because we need help. We need a lot of help. That's it.
Thank you so much for sharing that. And I know that was a difficult decision. I have no doubt about that. It was a tremendously difficult decision, but that's what we have the study committee here to try to get our citizens help, because no matter what, it doesn't matter about economics, doesn't matter about race, doesn't matter about anything. This impacts all of our citizens across the board. And that's why we're here. And I want to thank everybody for coming as we conclude this. As I mentioned, each kind of meeting has kind of a theme. The next one will deal more on the economic side of it, like what are the services that are available. And I know some people may say, well, I brought my loved one home and their issue was more of a physical impairment. We're going to be talking about that too. So we're going to try to cover as much as we can. I can assure you of that, and that we're dedicated to trying to help everyone in this room and everyone throughout the state. So thank you guys for coming. Thank you so much.